Good morning and a very warm welcome to everyone. We are pleased to have Indian Menopause Society and HARobGyn associate with Jagsonpal and organize this grand second MMLCON 2023, which is Managing Midlife, Prevention and Solutions. Experts speak about the happy aging and happy senses. So we welcome the delegates to this conference, and please do put in your questions in the chat box or in the Q&A box, which will be answered by the experts present here today. We first begin with the Ganesh Vandana. We now welcome all the experts and hand over this mic to President HARobGyn, Dr. Ragini Agrawal, who has arranged this beautiful full day conference on the web. Along with her are Dr. Jyoti Malik, the Honorary Secretary of HARobGyn, and Dr. Saroj Kumar, Treasurer, HARobGyn. We are very happy to be associating with Indian Menopause Society, and we have with us Dr. Shobna Mohandas as the President today. We have Dr. Anju Soni, Secretary General of IMS, and Dr. Pushpa Sethi, the incoming President for IMS. So welcome to everybody. And now I hand over Dr. Ragini Agrawal, ma'am, as the President. Please do have your comments and then we can initiate.
Thank you, Deepika, for always your support. Namaskar, welcome to all seniors and colleagues. I'm privileged to present this program under the leadership of our President, Dr. Shobna Mohandas, who has devoted the whole year to the marginalized women who has given their life to shape us, the society, the kids, and whatever we all are today because of our mothers. But those mothers, when they become old, they are marginalized because of the problems, because of many, many things which comes gradually, seeps in their life because of the loss of estrogen, progesterone, and the aging. Loneliness, depression is the second name become those mothers. And as Madam Ambuja has recently we are discussing, she's very apt. She has told us that if they are not economically independent, then it really plays a havoc on them. I welcome you all seniors, and my today's program chief guest, Dr. Sunila, guest of honor, Dr. Atul Munshi sir, President Dr. Shobna Mohandas, immediate past President Dr. Ambuja, Dr. Pushpa Sethi, incoming President, Dr. Sudha Sharma, past Secretary and present Secretary, Dr. Anju Soni, my dear friend, Dr. Revati and Dr. Chalani is there. Jyoti has just joined. Secretary HARoBGyn and Dr. Vipasa, our incoming Treasurer, is there. Now I invite Dr. Shobna Mohandas to start the proceeding as a President of the Society.
So good morning, ladies and gentlemen. The new year begins with a mega program from Ragini Agrawal, MMLCON, and she has taken so much of effort. Happy Makar Sankranti, Lori, Pongal, and everything. And I thank the team effort from Dr. Ragini, Jyoti Malik, Deepika Chabra from Jagsonpal. All of you have taken effort to create 3-4 WhatsApp groups and call up people, and the whole Sunday is going to be breezing with academics. And a lot of effort has gone behind just listening. What people come here to listen, they just have to spend that much of time. But the organizers have taken a lot of effort to do this. And along with Haryana HARoBGyn Society, I'm sure the deliberations to follow will somewhere touch the heart of some woman somewhere. The chain reaction from teachers to listeners to caregivers to the patients or the relatives of people who listen to all this. Somewhere it will touch some heart somewhere. Wish you all the best. I'm happy you're doing this for us.
Thank you, Dr. Shobna. And a note of welcome from Dr. Anju Soni, the President Secretary General, and recently she is elected as the next president after Dr. Pushpa Sethi. Congratulations, Anju.
Thank you very much, Dr. Ragini. I'm having a very bad laryngitis. At the offset, I welcome everyone and congratulate you for such a beautiful program.
Over to Dr. Pushpa Sethi, who is one of the organizers of today's program.
Very good morning to all of you, and Ragini, really great effort from your side, and congratulations for all that you have been doing all along for academics. And I'm very sure this is good. Today, though it's a cold Sunday and it's a Sunday holiday, but I'm very sure the topics are so good, and the topic that we have touched, we have always focused on adolescents, young age group, perimenopause, postmenopause, but geriatric medicine, we have really never touched. It's a very, when I was doing my topic, I came across so many new things which were new to me, and I'm sure our knowledge is going to be, enhanced by this lovely conference today. And we are going to consider geriatric medicine as a very, very important part of menopause learning. Thank you so much.
Thank you, Dr. Pushpa. And Dr. Saroj has joined. I cannot do anything without Dr. Saroj. That is on the record. And my other hand is Jyoti. So after this welcome by the all IMS stalwarts, I will hand over the inaugural ceremony to Jyoti. Welcome, Alka. I invite Chief Guest, Dr. Sunila Khandelwal, Madam. Guest of Honor, Dr. Atul Munshi Sir, President Dr. Shobna Mohan Das, Secretary Dr. Anju Soni, incoming President Dr. Pushpa Sethi, immediate past President Dr. Ambuja, Treasurer Dr. Vipasa, and past Secretary General Dr. Anju Soni, Dr. Sudha Sharma, and from Gurgaon Menopause Society, the first president of the Gurgaon Menopause Society, Dr. Alka Mathur, Dr. Saroj Kumar, Dr. Jyoti, and all the dignitaries who are present here, please join the formal lamp lighting. Over to you, Deepika. Thank you, Deepika.
It is my privilege to invite such a great dignitary, our guest of honor, Dr. Munshi Sir, for this, to start today's ceremony. Professor Dr. Atul Munshi Sir is a consulting obstetrician, gynecologist, director, Munshi Group of Hospitals, Ahmedabad. He has been a professor head at GCS NHL Medical College, Ahmedabad. He is associate editor, journal Life Midlife Health. He has been the IMS representative to Asia Pacific Menopause Federation, APMF. Sir is the IMS representative to International Menopause Society in 2017-2018. Sir has been the FOGSI representative to CEFOG in 2016-17. He has been chairperson of ICOG, a president of IMS, and a senior vice president, FOGSI 2007. Sir is on editorial board of the Pediatric On-Call Journal and has contributed so many chapters. And it is indeed a pleasure to have you, sir, on this platform. And I invite you to say a few words, sir. Thank you.
Good morning, everyone. Thanks for the kind words. And happy 2023. We are here for yet another web conference. Happy aging, happy senescence. This is curtain raiser for MMLCON at Calicut exactly 1 month from now. If you go through the brochure, you will find it's a fully loaded program with faculties from all over India. I must appreciate the efforts made by Dr. Ragini, Dr. Jyoti Malik, and team of Haryana OB-GYN Society under able guidance of our IMS President, Dr. Shobna Mohandas, and IMS Secretary, Dr. Anju. I'm sure at the end of the day, we'll be enriched in many aspects of women health. As we are approaching end of our constitutional year of IMS, let me take this opportunity to congratulate the current team of IMS for year-round multifaceted activities. To name a few, weekly President's webinar every Tuesday, dance exercise every Sunday. Everybody's all interested, even few males were also joining. Every Sunday, visiting old age home by different societies periodically, zonal conferences and regular organizational meetings. Presence of organization is felt nationally in FOXY, ISAR, etc., and internationally in CAMS, APMF, SAFAMS, and FIGO. We are proud of our members, Dr. Duru Shah, Dr. Sunila, and Dr. Jyoti, for international representation. I'm sure our founders, Dr. Ramaben, Dr. Urvashi, Dr. Behram, Dr. Rashmiben, must be saying, निकले थे हम अकेले, लोग जुड़ते गए, कारवा बनता गया. IMS is in the way of unstoppable progress. And I'm sure incoming team of Dr. Pushpa Sethi and Dr. Bipasha will continue the same. Once again, thanks to Dr. Ragini for involving me in this academic activity. I request all the people who are there that we should now have a definitive place for our IMS headquarters. Let's see that in years to come, we might think of it and start having our own premises where we can start the thing. Thank you very much. I'm awaiting a nice academic program. Thank you very much.
I request Dr. Ragini ma'am to please thank Dr. Atul Munshi with a few words, ma'am.
Thank you so much, sir, for always guiding us, and you are always a call away and never say no. It's our proud privilege to present you with this memento of our love, affection, and respect in recognition of your extraordinary contribution to menopause medicine from the organizing team. It will reach to you by courier. Thank you, sir, for being here.
Thank you. Thank you very much.
So it is actually a proud privilege to have you, ma'am, here today on this platform. We are honored. Ma'am is a senior consultant gynec director, midlife, women healthcare and menopause center, Fortis Escort Hospital, Apex Hospital, Jaipur. She has been ex-member board of trustee, treasurer, secretary general, CAMS, International Menopause Society. She has been the past president of Indian Menopause Society, and she is ex-medical superintendent, PHOD, MG, MUST, Jaipur. Ma'am has a vast experience of teaching, of clinical and administration for the over last 38 years as a faculty at government and private medical colleges. She has been holding such prestigious positions and peer recognitions in various societies in different capacities in IMS, BMS, NAMS, EMAS, ISGEs, CEPHOMS, APMF, and FIGO. Ma'am has been the pioneer of the first menopause clinic in Rajasthan in 1997. She is also the founder editor of the Journal of Midlife Health. Now we all go through this is now such a prestigious journal that we go through for our menopausal problems. She has received advanced training at US and has lectured at many platforms, has received various awards, Award of Excellence 2016 by the International Menopause Society and by International Wolf Ocean IMS, CMS 2018 for furthering women's health, and Award of Exemplary Services to Board of International Menopause Society. So it is indeed a pleasure, ma'am, to invite you and have blessings from you. Over to you, ma'am.
Thank you so much. It was truly, I'm really overwhelmed and presently delighted to be with you all virtually. And I bring greetings from USA. I'm again at USA, but I could not resist myself to be with IMS family. So in spite of time change, right now I'm talking from California. So I bring greetings to you, and it's a wonderful Webcon. And thank you, Haryana OB-GYN Society, especially President Dr. Ragini, the national convener of the IMS Project 70+. So I think she has kept the theme in her capacity of, the 70+ project. And of course, IMS team led by the President, Dr. Shobna, for the warm invite, I thank. And the theme of happy aging and happy senescence, it reminds me again my US visit way back in 2001. That was my third visit to US after 1907. When I opened the chapter. And I'm glad to share, I was lucky to participate in New York Menopause Group that time in way back 2001, where International Menopause past president, recently he's been now become the past president, Professor Steve Goldstein coined a new term of GERIATRIC. So I really wanted to share this, and this is how it is coming up, and which it really merges this GERIATRIC term he coined in 2001, and which merges menopausal medicine with geriatrics. And in my most of the lectures, I show that slide, how the graphically he has shown it. And good thing is that later the concept was published and cited in many articles. So this seems to me very apt to discuss the issue still senescence for improving the quality of life by decreasing the morbidity and mortality in aging females. And it's high time to share the wisdom and the experience for developing preventive strategies and health promotion programs with other organizations, especially Geriatric Society, I should say, Endocrine Society, IMA, General Practitioner Society, Yoga Foundation, NGOs, and I think most of the our baby societies and other chapters, they are doing this, but I think we have to encourage furthermore, especially Geriatric Society. So, and I'm happy that the selection of the topics in the galaxy of chairpersons, the slate of experts, of speaker, panelists, they all guarantees an exciting Webcon, which will be likely to encourage deep intellectual discussion and interaction. So I wish all the success and hope we will be able to reap the clinical benefits through this academic exchange program. I'm happy to note the session on the felicitations. So my congratulations to all stalwarts. Session 4, I think it is on for the jewels of menopause. This is again another a thoughtful creation by Ragini, which is continuing. So I'm once again congratulate you, Ragini, for this. And I also take opportunity to congratulate the newly elected team 2024-25, Dr. Anju, Sudha, Jyoti, Hepsiba, and I extend my warmest wishes for the new year to all of you, and with my cyber hugs on this day. May you empower yourself and help the mature women group you serve to lead a happy, healthy, and productive, peaceful life ahead. So once again, accept my heartfelt thanks for giving me this honor. Long live IMS family, and wishing all the best for the Calicut conference, Dr. Shobna and the team. See you there. Thank you so much.
Thank you so much. Thank you, Dr. Khandelwal ma'am, for joining us from overseas on this beautiful Sunday. And we are really honored. And I now invite Dr. Ragini to say a few words and honor our chief guest.
Words are not enough to thank you, madam. From California, you have taken a time to join us. Even you have never told me even that you are not available in India. That's the greatness. You never said that shows your love and your passion for the menopause. And we all know that you have made a proud IMS in the whole world. Thank you so much for joining today. And from the organizing team of IMS and the HARoBGyn, we present this memento of appreciation to you in recognition of your extraordinary contribution to menopause medicine. Thank you again, madam. Thank you so much.
Thank you so much, Ragini. I love you all. And it is my passion who brings all these things together, and I can't resist.
Thank you so much. And now I invite Dr. Saroj Kumar, our organizing secretary and the treasurer of the HARoBGyn, to give the vote of thanks.
Today on this Sunday morning, we all the stalwarts are here, and Dr. Ragini. First of all, I would like to congratulate Dr. Ragini.
Thank you, Dr. Saroj. Now we will move towards the main conference. For me, the most important thing are the mothers who are marginalized because of empathy, lack of funds, or lack of knowledge in our society. And whatever each of us, and I can say the independent women like us in that time when it was not so easy to be the independent, are really because of our mothers. And when I saw the mothers or mother-in-laws, they are not having a good time, it really pains me. And we are all approaching towards the menopause. As I always say that the menopause is an eternal truth. Each of us who are sitting here, most of us, the senior faculty is 60 plus. And we are all moving towards that age, which is so important to really take in our hand our health at this time. Because when the time will come, say post 70, 75, if we have not taken really a serious interest in the menopause medicine of the younger women up to 65 with the definition of the WHO, we are not going to give the proper health management to the older women. Because today's the WHO definitions has changed, and the older women, they are beyond 70. So I really thank everyone who has joined today from the delegates. They have taken their time on the Sunday for a subject which is not very lucrative. Even they all come here and joined. And the way IMS is progressing day by day, it is really heartening. We are having new chapter and people have a real interest in the IMS. And not only what we have done the whole year under the guidance of the Dr. Shobna Das, Dr. Jamna Devi, who is our South Zone coordinator, and she has done the most work for this 70 plus program. She is going to present what we have done for the 70 plus women. Over to you, madam.
Yeah, I think Karkinos has again approached me that they want to do the HPV testing. Is it possible to get Lions Club and Rotary Club to join? The way we tried to do it, we sent apps for all the gynecologists. Nobody responded. Out of 4,000, only 4 people came for self-HPV testing. So can we spread it out to all the Lions Club and Rotary Club so that they do the app, send the apps to the common people? Gynecologists are not bothered about their health.
So, madam, as far as the Lions Club is concerned, now it is called their female version, Lioness, is not there anymore. It is, so Indian Lioness Club has not merged in the Lion Club because the Lion Club is governed by the males, and we always think for the woman can have more empathy. So there's a All India Lioness Club. And from that side, because I am one of the state representative of the Lioness Club, I can take this opportunity because
so we need to take this forward.
Yes, this year.
It's the self-testing that we want to propagate, because self-testing doesn't need exposure. Most gynecologists don't like to lie in front of another
ordinary person is afraid of taking self-testing because so many people I told, we got to put something into their vagina which is so sharp and all. Taking the smear, they are all little scared. Even to put the vaginal tablet also, they are scared. Like that, maybe they are preferring this instead of going to the labs, which is costing about 2,000, 2,500. Yeah.
Hello.
Welcome, madam.
Congratulations on this excellent program. And I think, 70 plus Shobna's brainchild for this year has been very successful, something which IMS had never looked into. Saroj did talk about that Badi Didi, Choti Didi concept, But this year is the year of implementation of that 70 plus. And I see even Hyderabad and so many of you all doing such good work with the 70 plus. That is one. No, in line with your conversation on cancer screening and, the self thing, there are, what all points have been brought out by everybody is very good, that, we still need to do a lot of screening, and you should be promoting both, because like Madam said, Dr. Ambuja, like some people are skeptical about doing their own thing in India, even putting the tablets. So, and like you said, we can promote both of them, but the importance is promotion of both of them. Either way, like you said, even if you put it to 4,000, only 4 people responded. We had done a survey on how people take care of themselves. And that time, nobody was doing their own pap smears in the gynecology. That was 2012. So, but now I think people are probably doing the advantage. Another advantage of, the gynecologist doing for the patients. Maybe this can be pushed more for the gynecologists, the self-HPV. Because a lot of the gynecologists are very hesitant. Kahan jaye, kiske paas jaye? They are little, hesitant, as we see. But for the patients, it's a midlife health. No? When you're talking about midlife health, it's not just about the screening of the cancer cervix. Then you're teaching them breast examination. Then you're running a, just a general checkup. So maybe for the patient, for the women in general, promoting that entire concept is better than only a cancer screening from the IMS society.
That's also good. Yeah. We should promote health checkups a little more.
A little more, including this and this. If you're getting something for 1,000, which would probably be a cheaper thing, and whatever, locally, whatever is available for anybody. But I think this HPV self thing should be promoted amongst the gynecologists who don't go to the doctors.
Exactly.
Yes.
We'll resend the app again now.
Correct. So best wishes to all of you.
It was a wonderful, wonderful discussion by our stalwarts. And the key points that we come up is that we have to promote all these apps to our general public, to the gynecs, to promote the HPV app there, promoting the health checkups, promoting HPV self-testing for gynecs especially, because gynecs do not go to other gynecs for their testings. We come on to the scientific session where we have our first keynote address, and our speaker is none other than Dr. Ambuja ma'am. And Dr. Ambuja, to chair this session, we have Dr. T. Sundari ma'am. Dr. Sundari ma'am, she is working as the HOD senior consultant at KIMS Hospital, Secunderabad. And she was formerly head of department of the Gandhi Medical College. She is chairperson of the ONCO committee of IMS. And ma'am, I now invite you. I have the opportunity and I have the pleasure to have Dr. Ambuja's ma'am CV reading this great CV. Ma'am is the president IMS Society 21-22, and she has been a research committee chairperson for CEFORMS. Ma'am is the retired professor head, Osmania Medical College. Ma'am, I now invite you to take her topic on metabolic syndrome in senior women.
I am so overwhelmed with joy. On this auspicious day, started the program like opening batsman. As Ragini always tells, her favorite word I can say, menopause, the eternal truth. Yes, that is true. And today, she has kept it for mainly a prevention and solution. So let us stick on to that only. And menopausal metabolic syndrome is like a tsunami. Without telling, it just hops on us. That is in the perimenopausal and menopausal women. For that, we should know what is metabolic syndrome. It is not a disease in itself. Instead, it is a cluster of metabolic abnormalities which are risk factors for cardiovascular disease and diabetes mellitus. And metabolic syndrome, it increases the risk for non-alcoholic fatty liver disease, hyperuricemia, polycystic ovary syndrome, obstructive sleep apnea, and basically it is a lifestyle disease. You see many of these things in the menopausal age, they go and die with the physicians, cardiologists, or urologists and all, but they will never come to us. But the death because of these things is rampant because the age of the menopause, age of the longevity of the person has increased. How then, when it is a cluster of symptoms, how can you say that patient is suffering with the metabolic syndrome? We have so many definitions like WHO definition, this one, that one, UK and all, but what we ideally follow Indian circumstances is International Diabetic Federation definition, that is presence of central obesity. It is estimated by the waist circumference more than 80 centimeters or plus any one of the following, means the central obesity is a must, always it is there, and added to that 2 more of the following: BP 130 by 80 millimeters of mercury when it is more than that, fasting blood sugar more than 100 milligrams, and serum triglycerides more than 150 milligrams per DL, and reduced HDL. This is more important. We don't give much importance to the LDL because HDL is a cardioprotective. When serum HDL is decreased, that's a risk factor for the cardiovascular disease. So these are all the things leads to the atherogenic dyslipidemia. This is called the syndrome X, and the Indian prevalence, it is increasing as the age of the longevity is increasing. It is increasing from 32.5 to 48%. And by 2020, estimated deaths were 42% of the total deaths were because of the cardiovascular disease. And stroke especially, it was 545 per 1 lakh. We never thought that it is there. And hypertension, all the other problems have increased. So globally also, the longevity of a person, number of people living more than 60 years, by 2025, it is 2030, it is going to be 16.5% of the total population. And by 2050, it is going to be 21.5% of the population. In India, it so happens, number of young children, young people below 50 years are decreasing, and older population are increasing, and it is 3 times more than the younger population. With all these things, we should know how to prevent if we know the risk factors for that. Risk factors are modifiable and non-modifiable. Better we know the modifiable risk factors than non-modifiable, because nothing much can be done for the non-modifiable. Obesity, it has increased enormously because India has become a hub for obese people because of the sedentary lifestyle and eating habits. Eating junk is more not working, and more of IT technology always with the computers. Even we started using more of computers. And second is, though we are telling so many times, smoking has increased so much. Whenever we go, number of youngsters smoking has become a lot. Smoking, what happens? The high density lipoproteins comes down if the smoking is present. So if they smoke in the premenopausal period, the exposure or the cardiovascular disease becomes 3 times more. That is why prevention at that age, younger age, is more important. And excess of alcohol, a little of alcohol always is welcome because it is a vasodilation will be present. But excess, when it becomes, it is harmful to the liver. Of course, stress and antipsychotic drugs are present always. Among the non-modifiable important things is the hypertension, because it is a genetic factor that is present. Because hypertension, if it occurs below 55 years of age, it is a genetic factor. Or a first degree relative dies of the hypertension. This you cannot control. And diabetes mellitus. Some of the factors which are unique to the women. One is early menarche, if it is there. They are exposed for the estrogen for a longer time, and sudden depletion of the estrogen leads to the metabolic syndrome. And PCOD is another one. What are the factors in PCOD? Again, it is the central obesity, irregular menstruation, where ups and downs in the estrogen level will be present. More than just estrogen, It is the ratio between the estrogen and testosterone is more important in causing the metabolic syndrome than just depletion of the estrogen. And menopause, as it is, age is not a factor. It is not an independent risk factor, but how many years the patient is living after the final menstrual period is important. Long number of years that are present, ups and downs in the estrogen level that is there, the incidence of metabolic syndrome is more. That is why the patients having the hysterectomy or people who had premenstrual syndrome, they have got 3 times more of hypertension, and pregnancy complications like preeclampsia, risk of cardiovascular disease is 2 times more. And GDM person suffering, 40% of them, they will end up with the diabetes mellitus after later life. And they are likely to get diabetes 10 years earlier than the normal person. And spontaneous abortion, stillbirth, they are all the risk factors for the cardiovascular disease. So basically, what is the pathophysiology we should know to prevent that one? One is the menopause is a sex steroid hormone dependent state. It increases the vulnerability to disease in hormone responsive tissue. What are they? Like bone, brain, and cardiovascular system. Whenever there is any estrogen deficiency is there, the nitric oxide depletion, which is a pro-inflammatory, pro-oxidant, that is, this leads to the free radical release and pro-apoptotic and pro-thrombotic. All these things are the risk factor for cardiovascular disease. The simultaneous occurrence of insulin-resistant and visceral obesity is associated with oxidative stress, as I already told you, inflammatory and pro-thrombotic factors. This slide is very important, where we have the menopause is a biological aging. We have chronological aging and biological aging. Chronological aging, nobody can stop it, but biological aging, it is only 25% genetic and 75% epigenetic. What is that epigenetic? Like smoking, dust, everything that comes into that one. Depending upon that, menopause occurs. That is why the premature menopause is more nowadays. It leads to the telomere shortening, DNA damage, and oxidative stress. And whenever there is oxidative stress, free radicals are released. That is the oxygen, H2O2 and oxygen, that is superoxide, that are released inside. Normally, if there is no damage because of the oxidative stress, mitochondria, which will remove all these things. But when it is not removed, what happens? They are accumulated in the cells, which leads to the DNA damage and shortening of the telomeres. And finally, it leads to the NCDs, that is non-communicable diseases, which finally leads to the metabolic syndrome. So, mutation of mitochondrial DNA or damage due to epigenetic factors leads to the immunosenescence and NCDs. Whenever it is accumulated here, it damages the endothelium of the cells, and then it leads to the endothelial dysfunction, and all the factors will follow. So, in short, we can say a shorter telomere, if it is present, it is the early death and densities, and long telomere is the healthy aging. Whenever there is any estrogen that is lowered, added to the obesity that is present. Even though we say menopause or perimenopause will not increase the fat that is present, even the weight gain may not be there, but fat distribution, that's more important. Means the fat will accumulate in the viscera. So visceral obesity is more common. The BMI may be normal. Basal metabolic index, that is, it is normal, but visceral fat accumulation will be more. Short telomeres possibly promote early beta cell senescence, which leads to the diabetes. resulting in reduced cell mass and impaired the insulin secretion and insulin resistance. These are the factors that happens. What happens if the obesity, the central obesity, if it is present? The central obesity, if it is present, more of hypertriglyceridemia that is there, which lowers the adiponectin level. Adiponectin, that is the culprit which causes damages, all these things where the liver damage and retinopathy, sleep apnea. Never thought that people will die of the sleep apnea. This is one of the complications that occur. In the perimenopausal weight gain, it is only 0.55 kg per year. It is predominantly visceral. That's what we should know. And obesity leads to increase in the leptin resistance. So whenever there is any low adiponectin that is there, the low HDL, again the same. And then increased triglycerides and increased insulin resistance. These are all the factors that will happen. With the age, cells become less accurate at detecting the amount of glucose or fat that is there in the body. So some fats and sugars don't get processed properly. That is why they will become fatty. Aging cells accumulate an excess amount of fat, not because older people ingest a lot of fat, but because the cells cannot act or recognize it. This can affect the insulin and insulin-like growth factor 1, which play a role in diabetes. All the time we are talking, the estrogen is the culprit. Can we give estrogens to get it back to normals? What is the role of menopausal hormone therapy in that one? But mind that I already told you, it is not the estrogen only thing that is affected. It is the estrogen and testosterone ratio is important. Though testosterone is not increased, estrogen depletion leads to the differentiation between the ratio of estrogen and testosterone. There is a differential effect on atherosclerosis and clinical events according to when MHT is initiated in relation to menopause. All of us know that there is a window of opportunity, what always we study. And hormone therapy reduced atherosclerosis in progression in the recently menopausal group. But it has got no effect or worsening effect when you give it to a older age woman. That is why it is very clearly mentioned to prevent primary or secondary prevention of the cardiovascular disease, you should not give the MHT. But only when you give below 60 years where atherosclerosis has not set in, it will have a positive effect. But later on, when already atherosclerotic patch is there, because of the vasoconstrictive effect, because of the deficiency of the estrogen, these plaques are released into the circulation, causing the myocardial infarction. So it was not seen in the elderly group or postmenopausal. After 10 years, you should not give the hormones. What is American Heart Association current recommendations about giving the menopausal hormone therapy in the elderly person? MHT not for sole purpose of primary or secondary prevention of CHD. This is the third time I'm repeating because we should remember that we should not give for the prevention of heart disease. MHT should not be initiated within 1 year of cardiac event, even for other indications. Suppose heart pressure she has got, suppose in the one previous year she has got the heart attack, don't give it. Risk of MHT is seen in the first year of the, whenever we start the first year of the hormones, and in the inflammatory state, if you give, where she had myocardial infarction in the previous year, it will become the worst. So don't give it. While on MHT, if there is a cardiovascular event that occurs or immobilization because of the fracture or anything, discontinue MHT, don't give. Oral estrogen therapy is contraindicated with women with DVT, and transdermal is preferred. Nowadays, transdermal estrogen is available They are going to launch in Bombay already. It is there. In Hyderabad, they are going to launch in 2 days. However, individualization of treatment often ensure best outcomes. Do not deny the benefit of HT in the deserved candidate. Now coming to the preventive measures, along with pharmaceutical treatment, whenever necessary, please follow these things. Take care of the obesity, physical activity, treating the disease process such as dyslipidemia, that's very important. Low fat, low calorie, vegan diet is always very good. But one thing you see, weight loss is not easy. People will walk for 10 kilometers every day, but still they will not reduce even a single kg weight. Why it happens? There is BMR, that is basal metabolic rate, is reduced in menopause. Each fat cell in store is a store of triglycerides. So once they accumulate fat, the triglycerides, each fat, 1 gram of triglycerides gives 8 calories, but only glycogen, if it is present, when glucose is there, it will be converted to glycogen that gives only 1 gram is equal to 1 calorie. Fat is present, it's more of calories that is there. Vigorous dieting, leptin will come down and less energy expenditure that is there. Everything is fine, the fat will come down. But once we stop dieting, the fat cell signaling will be there. 300% more of leptin is secreted and fat cells will swell, leading to obesity. That is why even though vigorous dieting is done, temporarily they will reduce weight, but they will not, the rebound phenomena will be present. So no shortcuts for the exercise. Please do the exercise. Adults who performed more than 150 minutes of walking per week had longer telomeres than those who did no regular exercise. So this is very, very important, doing all the exercises. All of us know what it is. So finally, to emphasize, incidence of metabolic syndrome is increasing in menopause, and cardiovascular disease is a major cause of mortality in postmenopausal women. HDL is cardioprotective, and whenever estrogen deficiency is present, HDL is decreased. MHT is only for relief of vasomotor symptoms, not for primary or secondary prevention of MS. Balanced diet and regular exercises from early reproductive age can prevent metabolic syndrome. Menopause is not a disease. Learn to enjoy the change. So, the old age is not a curse or anything. And she says, I moved my knees, I turned my neck, everything made the same noise, that is the crack. I came to conclusion, I am not old, I am crispy. Thank you very much for the patient listening and giving me the opportunity to talk. Thank you, Ragini.
Thank you so much. It was absolutely amazing talk to start with. After this great talk, we have the second talk on anemia by our next speaker, Dr. Pushpa Sethi ma'am. For chairing this session, we have Dr. Lakshmi to chair this. Dr. Lakshmi is the additional professor, Department OBG from Kozhikode. She is also president of Calicut Menopause Society. She has been the secretary of this same society in 18 to 22. And she is also the vice president of Calicut OBGY Society. And I now request Dr. Lakshmi ma'am to please speak to introduce Dr. Pushpa Sethi ma'am.
A very good morning to all of you. At the outset, I would like to thank Dr. Ragini and her team for organizing such a wonderful webinar and making me a part of this. It's my pleasure to introduce Dr. Pushpa Sethi, our next incoming president, Indian Menopause Society for 23-24. A multifaceted personality with a very impressive track record. Just to name a few of them, she has been the chairperson, Midlife Management Committee, FOXY, 2015 to 18, past president of IMA Gurgaon. She has been the recipient of the Lifetime Achievement Award by IMA Gurgaon, and she has done a lot of social projects with a lot of reach out to health-related issues. notably eradication of anemia. And I think Madam will be speaking on her pet topic, anemia. So over to you, Madam.
Thank you so much. And at the outset, thank you, Ragini, and thank you all the organizers of this conference. It's always a pleasure to be on the IMS platform, my passion. So when I got this topic from Ragini, I had to get back to her. I said, anemia, we normally talk of in adolescents, in pregnant ladies, or in the younger age group. When I started looking up for anemia in the geriatric age group, it was something new for me also. So, but friends, anemia in the elderly is a cause of concern, is a great cause of concern, should never be taken lightly, because, number one, we do not reach out. These people do not come to us. We do not reach out to them. We are normally concerned with mostly with the perimenopause, postmenopause, early postmenopause, hormone therapy. But this is absolutely a new area we are treading on. And we have a lot of learning to do on this. So what are the challenges, special challenges that we face when we are talking of anemia in the elderly? Anemia in the elderly is more challenging than that in the general population, but why? Vague presenting complaints of the patients are there, non-specific symptoms, poor history due to an impaired memory can be there. There is at times absence of attendants or relatives who can really put in some more information to you. Presence of one or many underlying comorbidities which may mask the symptoms of anemia. So mostly they will have some or other comorbidities attached. Anemia may be because of them, or maybe a separate presenting symptom but gets masked. A tendency to dismiss anemia in the elderly as merely physiological. So anemia is a sign and not a diagnosis per se. The presence of anemia may be a marker for more severe underlying disease. Failure to correctly diagnose and treat anemia may be the reason for poor response to treatment for other coexisting disease conditions. So anemia has to be taken care of once you are dealing with the other comorbidities. Therefore, it is imperative for the clinician at the first point of contact of the patient to focus on identifying geriatric anemia. A prompt identification of anemia and its subsequent management spells successful outcomes of other associated illnesses that you may be taking care of. Anemia in the elderly can lead to these many problems. There can be increased frailty, poor exercise performance, diminished cognitive function, risk of developing dementia in the long run, decreased mobility, increased risk of recurrent falls, low bone density, low skeletal muscle density, and increased rate of major depression. So this is a very interesting study I went through because it was an Indian study actually, and a very recent one. And it's a small study, but then it has taken, it's about anemia in the geriatric age group. This is a cross-sectional type of study in a tertiary care center somewhere in Tamil Nadu, including 100 female patients aged 60 years and above, and whose hemoglobin was less than 12 gram per DL. And this is the WHO requirement. WHO says in the geriatric age group, anemia is considered when hemoglobin is less than 12 gram. Clinical history, complete blood picture, and peripheral smear were obtained in all patients. Serum iron profile was done in all patients with micronormocytic anemia. Vitamin B12 and folate assays were done in patients with normal macrocytic anemia and those with pancytopenia. Bone marrow studies and endoscopies were done in cases wherever it was deemed appropriate. So what was the result of this study? So here, the 100 patients that were there, 51 were in the age group of 60 to 70 years, 34 in the age group of 70 to 80 years, 13 in the age group of 81 to 90 years, and 2 were in the age group of 90 plus. What were the results? Surprisingly, 42% had hemoglobin less than 7 gram, 50 had hemoglobin less than hemoglobin between 7 to 9 gram, and only 8 had hemoglobin more than 9 gram. The serum iron profile picture was less than 30 was in 24 patients, 30 to 99 in 28 patients, more than 100 in 31 patients. Serum iron was less than 50 in 50 patients, 50 to 150 in 28 patients, more than 150 in 5 patients. Serum total iron binding capacity was less than 250 in 20 patients, 250 to 450 in 32, and more than 450 in 31. TSAT was less than 20 in 22, 25 to 20 to 50 in 46, and more than 50 in 50. So this is the total iron picture of these patients. Upper GI endoscopy had to be done in a few patients, and in 5 patients, it was found that they had erosive gastroduodenitis. 3 patients had esophageal varices. 3 patients had atrophic gastritis. Duodenal telangiectasis was in 1 patient, antral ulcer in 1 patient, stomach fundus proliferative growth in 1 patient, H. pylori gastritis in 1 patient. And the final diagnosis was, according to the etiological classification, the nutritional cause was in 45 patients. 50% of these patients were nutritionally deficient. Iron deficiency anemia was found in 24, B12 deficiency was found in 18, and folate deficiency was found in 3. Anemia of chronic disease was found in 40, hematological malignancies in 7, and unexplained anemia in 8. So in India, you see the anemia because of nutritional deficiency has a greater percentage of patients. But in Western countries, unexplained anemia is to the tune of 1/3 patients. So here in India, the nutritional deficiency in these group of patients is very high. Now, coming to the etiology of anemia in the elderly, the etiology of anemia in older patients is complex and falls into 4 often overlapping categories. Number 1 is deficiency of nutrients, including iron, vitamin B12, and folic acid. As we have seen, it comprises in that study to almost 50% of patients. Anemia of inflammation or chronic disease, congestive heart failure, malignancy, autoimmune disease or infections, and then coming to chronic kidney disease, very common in this age group. Hematological malignancies, for example, chronic lymphocytic leukemia, multiple myeloma, myelodysplastic syndrome, Hodgkin's disease, then unexplained anemia of aging, or UAA as we will label it, which is diagnosed mainly by a criteria of exclusion. Now, coming to the nutritional deficiency anemia, according to Guralnik et al., and they have done a lot of work on geriatric anemia, about 1/3 of cases of anemia in the elderly, and this we are talking of the Western patients, are attributed to nutritional deficiencies. Iron deficiency anemia is the most common cause of nutritional anemia and accounts for about half of these cases. Vitamin B12 and folate deficiency with an incidence of 11.5 to 25.3% represent about 4.6 to 10.5 of anemia cases in the elderly. IDA can be due to the lack of dietary supplementation or because of malabsorption or chronic blood loss from the GI system. Malabsorption causes include Helicobacter pylori infection, autoimmune gastritis, and celiac disease, whereas those due to blood loss comprise esophagitis, gastritis, peptic ulcer disease, chronic polyps, angiodysplasia, colorectal cancer, urogenital blood loss, and drugs such as non-steroidal anti-inflammatories, aspirin, and anticoagulants. So you see, there's so many, comorbidities attached. And you have to really go through these patients very carefully so that you can give them the right direction of treatment. Then coming to the B12 and folic acid deficiency, anemia associated with B12 deficiency occurs primarily due to the B12 malabsorption. There are several risk factors for B12 deficiency, but the most common causes of food is the food cobalamin malabsorption and pernicious anemia. Folate deficiency, the occurrence has decreased because of the fortification of flour. Yet some causes include poor diet, chronic alcoholism, malabsorption, hemolytic anemias, and conditions that increase cellular proliferation. Use of anticonvulsants and methotrexate may also be a contributing factor here. Then anemia due to chronic disease and inflammation accounts for 1/3 of cases of anemia in elderly. Anemia due to inflammation develops in those with chronic inflammatory conditions such as infections, chronic heart failure, diabetes, advanced atherosclerosis, malignancy, and autoinflammatory conditions like inflammatory bowel disease and rheumatoid arthritis. The aging process is accompanied by a reduction in autophagy, as well as an increase in pro-inflammatory cytokines and reactive oxygen species. Chronic inflammation happening in the body, a lot of things are attributed to that because of the vasculitis happening and because of so many accidents happening in the body. And this is a slow process that is taking place that you don't really know what's happening, and can lead to so many varied problems in the body. And these contribute to a low-grade inflammatory state. And now this has been given a name actually, and it is called inflammaging. So because of the aging process, the inflammatory process happening in the body lead to so many conditions that can, and anemia can be one of the conditions happening there side by side. Anemia due to chronic disease and inflammation. There are three primary mechanisms of action that have been associated with anemia. Inhibition of erythropoiesis induced by the inflammatory cytokines, which inhibit the production of action of erythropoietin on the erythropoietic stem cells, through the expression of hepcidin. And this is also very important. Hepcidin is an acute phase protein secreted by the hepatocytes, and its transcription is increased in response to the activation of inflammatory cytokines. So this is a very important point. The third way is through the increase in erythrocytophages and reduced survival of circulating erythrocytes. Inflammatory cytokines and reactive oxygen species increase the likelihood of erythrocyte injury and eventual erythrosis. So the slow inflammatory process, the more we talk about it, the more we learn and how it damages the body. Now, coming to unexplained anemia of aging. The unexplained anemia of aging represents the none of the above category, a category that occurs when patients present with normal laboratory parameters, everything seems normal, allowing exclusion of nutritional, inflammatory, and kidney-related causes. So when you exclude that and still patient has anemia, it is unexplained anemia of aging. Guralnik et al. Demonstrated that in elderly, the unexplained anemia of aging accounts for approximately 1/3 of cases associated with anemia in this age group. The age-associated increase of EPO in those with hypertension or diabetes is significantly less or negligible as compared to those without unexplained anemia. It can be because of androgen deficiency. It can be because of low vitamin D levels also. These two slides I will not go through. Then unexplained anemia of aging. The causes of unexplained anemia are likely multifactorial, with variable contributions from renal disease, endocrine deficiency, blunted erythropoietin response, chronic inflammation, androgen deficiency, nascent myelodysplasia, and other underlying conditions. There's something called clonal hepatopoiesis, which also leads to unexplained anemia of aging. Clonal hepatopoiesis is the alterations and selective mutations that occur in the hemopoietic stem cell line. The hemopoietic stem cell line undertake multiple rounds of divisions to sustain hematopoiesis and are susceptible to accumulation of mutations over a period of time. The prevalence of these mutations increases and accumulates with aging and provide a competitive advantage over the normal hematopoietic stem cell, allowing for the development of anemia. Now, coming to investigations, anemia can be classified according to the size of the erythrocytes. So normocytic mean cell volume is between 80 to 100. Microcytic is when it is less than 80, and macrocytic when it is more than 100 can be determined. Value of the mean cell volume, that is MCV, can elucidate the underlying disease. Most common causes of microcytic anemia in the elderly are iron deficiency. The macrocytic anemia in geriatric patients occurs mainly due to the B12 and folate deficiency, hemolysis, hypothyroidism, and myelodysplastic syndrome. Causes of normocytic anemia include anemia of chronic disease, malignant disease, CRF, chronic renal failure, infections, and bone marrow diseases. Elevated reticulocyte count can refer to blood loss or hemolysis. There can be moderate rise of ESR as a result of anemia itself. There can be elevated LDH levels. It is a frequent finding in malignancies. When low level of iron concentration is detected in the serum, the ferritin, that is the iron storing protein, should be measured. If ferritin level is high, anemia might be due to malignancy or chronic inflammation. The low ferritin level proves the iron deficiency is due to blood loss, malabsorption, or nutritional problems. Transferrin saturation is the most useful parameter for diagnosis of iron deficiency. B12 deficiency can be measured by serum methylmalonic acid level, besides detecting a low B12 level. Pancytopenia can refer to hematological malignancies, systemic autoimmune disease. Coombs test should be indicated if there is a doubt for autoimmune hemolysis. Flow cytometric evaluation of the peripheral leukocytes, measuring the protein content and calcium level of the serum, or looking for infective agents and inflammatory parameters such as the C-reactive protein might also be necessary. If the assumed diagnosis is a malignancy, then tumor markers should be checked. Now, coming to clinical aspects of the diagnosis, there are general symptoms and signs of anemia like fatigue, tiredness, paleness, tachycardia, hypotension. Jaundice is present in liver cancer, pernicious anemia, and hemolysis. Neuropathy and glossitis are signs of pernicious anemia, while cheilitis, chopped nails, and hair loss are characteristic for iron deficiency. In elderly, the first clinical symptom might just be confusion, sudden onset of dementia, or development of CHF. If anemia develops slowly, symptoms are not as marked, and patient has time to adjust to the lower erythrocyte value. And so she will not realize what's happening in that period when she's just, her body is adjusting to a low, falling hemoglobin. But if there is a sudden fall of RBC, like bleeding or acute hemolysis, or there is a malignant disease in the background, anemia is much less tolerated in this age group. Coming to management, indication of treatment is the presence of clinical symptoms. The frailer the patient, the more difficult to tolerate anemia. When anemia generates severe dyspnea, heart failure, or a profound impairment of brain blood circulation, a fast intervention is needed. Nutritional deficiency can be restored by supplementation. It can be oral supplement of iron, vitamin B12, folic acid. In case of myelodysplastic syndrome or chemotherapy-induced anemia, administration of erythropoiesis-stimulating agents or blood transfusion is recommended. Patients with chronic renal failure require not only regular EPO substitution, but often parenteral iron substitution as well. In case of autoimmune or autoimmune hemolysis, immunosuppression is recommended. RBC transfusion is not the treatment of choice here. It is indicated only in life-threatening situations. Treatment of the underlying disease is of utmost importance. Blood transfusion in the elderly has to be a cautiously treaded path, considering the risk versus benefit ratio, and has to be very careful when giving blood transfusion in this age group. Increasing age and cardiovascular status of the patients are important factors to consider while you decide for the blood transfusion. It is a safe and wise practice to maintain blood threshold of 7 to 8 grams per DL in the elderly for transfusion. So, only below this, consider transfusion. Above that, you can have parenteral iron or oral iron supplementation. So to conclude, anemia is prevalent in men and women over the age of 65 years and becomes progressively more common with age. Anemia is associated with decrease in functional capacity and quality of life and an increased risk of death from all causes. Wherever a reversible cause of anemia is identified and corrected, it is rewarding to note that we can significantly contribute to the overall improvement in the quality of life in the elderly, and their activities of daily living are extremely well enhanced. While aging is a physiological and inevitable process, staying healthy while aging is a basic right and a necessity for all. As physicians, it is our duty to bestow this privilege on the elderly by focusing on the vital issue of geriatric anemia. A focused approach is always the forerunner for better patient outcome. And love is beautiful, life is beautiful. Let it be a beautiful life, even in the geriatric age group. Take care of their needs, the smaller needs, and anemia is one thing that can be very easily overlooked if you do not keep that in mind. And these are the references. And thank you so much for a patient hearing.
Thank you, madam, for that very complete overview of anemia. Now, I would just like to add a very important point here that the European Society of Cardiology has come out with a few interesting reports saying that at least 10 to 20% of new onset cardiovascular events post-midlife is contributed by anemia. So we always highlight the importance of diabetes, hypertension, dyslipidemia, but I don't think anemia has ever figured in the list of precipitating factors for a coronary event. And the information that less than 12 grams should be considered as anemia in the elderly has even really not gone down well with medical practitioners. So I think it's a very important thing to take note of. And thank you once again for that excellent presentation. I would like to take this opportunity to extend a very hearty and very personal welcome to each and every one of you for the IMS-CON 2023 that we will be hosting at Calicut. So expecting to seeing you all of you there. Thank you very much, Dr. Ragini and team once again.
Thank you so much. Thank you.
Moving on, we have our next, the third talk for this session. To chair this session, I would invite Dr. Loveleen Sodi to please chair this session. Dr. Loveleen is the Director and Chief Consultant Gynae Infertility Specialty at Dr. Sodi's Healthcare Punjab. She has been the past president of the Menopause Society region of Chandigarh and the General Secretary of the Greater Chandigarh chapter. Dr. Sodi, over to you to invite our next speaker, Dr. Anju Soni, ma'am.
Good morning, everyone. At the outset, a very, very big thank you to Dr. Ragini Agrawal for inviting me to join this absolutely fantastic conference. The first two lectures itself have been par excellence, and I'm sure excellent ones are to follow. And it's a great pleasure to be introducing Dr. Anju Soni. She's very well known to all of us, but then just to update that she is the chairperson, HIV and AIDS Committee of FOXY 2022. Ma'am is the president-elect for IMS for 2024-25. She's presently the Secretary General of IMS 2023.
As Dr. Ragini mentioned, even I was perplexed, and then I thought about it. What about pelvic examination? We have been doing pelvic examination in young, in a reproductive age group, in other age groups. But what about menopause, where it is much more important? And with today's concepts of ultrasound and everything, we are not able to, none of the doctors are examining. Pelvic examination is the most important examination in all gynae patients. Very, very important in all gynae examinations, especially when we talk about menopausal women. When we talk about menopausal women, when I go through my presentation, you will see that, I would like to first congratulate and thank Dr. Ragini and her whole team who has organized this beautiful academic bonanza today. And I welcome all the delegates who are here early morning on our festival day and listening to this beautiful program. Menopause is a new chapter in the journey of life, and that is to be welcomed. Better planned by clinician and patient together to ensure a good health and optimum well-being in the years which are coming ahead for us. And when we are here, we are talking of, if you can see the photo down, this is a photo of Mrs. Soman, who is at her age 80 plus, is running with her son. This is a very inspiring, and I always look upon her. So we are all looking upon such icons in our, country. When we are talking about any menopausal woman, we all know that in our menopause clinic, which is our, main interest, that we have as many as menopause clinics, not only in government, but also in private practice, so that these women can be addressed, particularly, especially given time, which is very, very required need for today, and, which they should be taken care of. So when we look at this woman, we open up in the menopause clinic, we fill in this form, form which contains detailed symptoms with detailed history, family examination, and any kind of contraception history and all. And then examination of breast, and then followed by breast. Then comes the local examination, which means local examination of vulva, urethra, the vagina, cervix, and even PR. And when we are doing a PV, we have to look at the vestibule and look about the pouches and other things. So this is an area which I'm going to focus today during my talk, and I hope I will do justice along with the other things which may be there. So when we talk of when we are concerned of the menopause, what are the concerns we have? We all know that we suffer from vasomotor symptoms, psychological symptoms, mental disturbances, sexual disturbances, urinary symptoms, which start early and continue and progress till they are, as the age increases. and then osteoporosis, and of course other changes which we have been listening about. So I'm going to focus about urinary symptoms and sexual disturbances today. Again, hot flashes, night sweats are common, but when we talk of vaginal these symptoms, we all know that vaginal disturbance, dryness, and itch and irritation. It's very, very irritating for the patient. They may have some discharge, may not have some discharge. There are pain and other changes in the sex, and of course other problems. So this is what we are going to talk about today. Now, genitourinary syndrome is all of us know about. In first part, it contains painful sex, urinary urgency, frequency. Then, patient has burning sensation, patient has vaginal, dryness. And she can have a intralabial itching, which is very, very, irritating, which is very, cumbersome. She can't tell anybody, she's suffering in silence. And then there are recurrent vaginal infections, and of course, recurrent urinary frequency and infections. And then, of course, there is weakness in the pelvic floor muscles. So we all know that these are the symptoms which are very, very underreported. And though women are suffering, we know different studies shows that there are 27 to 84% postmenopausal women who are suffering, and only with an average of 50%, but it is only reported by less than 25%. And only 4% of these women attribute this problem to menopause. And it increases as the age of menopause increases. We all know that 65% of the problem is present in the first year of menopause, while this becomes to 84% 6-year menopause. And women think that it will abate, like hot flashes abate with the time. This will also abate without treatment, but no, there is, this problem does not abate with the time. It rather worsens, and it requires treatment. There is, though there is no relationship with the symptoms and the signs, but we still have to, work more in this area, so that if we can find some kind of system, signs and score, correlation, so that we can work better for the patient. So since very few people are attributed to menopause, they are now coming forward. It is our duty to ask leading question and find out about the signs which woman is suffering in silence, and tell them that there is a 100% possibility of relief of symptoms, and the treatment which they will be offered is safe for them, and we should offer them this system and let them come out of their problem. This symptom relief will be there depending on the duration of the illness they are having. So we can see from this beautiful graph that the vaginal dryness is the most important problem, followed by dyspareunia, vaginal irritation. Then, of course, there is pruritus, burning, kind of very bad feeling, postcoital bleeding, and urinary symptoms. So all these symptoms are there in this woman, and they are not coming forward and suffering in silence. This is all because of the lower level of estrogen. We can see that the estrogen levels are there, in very high. When we look at the vaginal dryness, the estrogen levels are more than 50, and the dryness is there when the estrogen level goes below 50. So beyond 50, the chances are less, and below 50, the chances are more. Again, coming to dyspareunia, we can see the same thing. The dyspareunia is more when the level goes below 5. But it starts with about 25, 30. Again, dyspareunia with discomfort, we can talk of estrogen levels which are again very low. And then pain is another important thing, for the women, where she's got this problem of estrogens which are again very low, and then of course burning sensation. Dr. Ambuja, can you mute yourself, please? Dr. Ambuja, thank you, ma'am. So estrogen hormone levels, when we look at this picture, we can see that the levels are less in the younger age, and she grows beyond, comes into the reproductive age. The levels of estrogen increase, and they start decreasing after the age of 40 in the perimenopausal age group, and they go on decreasing in the menopause, and as the age advances to 80s and 40. Hormone deprivation is the most important part. And that is why we have kept this as a urogenital syndrome. And female genital tract and urinary tract have common embryological origin of hormone receptor in the urogenital symptoms. And they are present in vulva, vagina, bladder, urethra, and musculatures, endoproliferation, sensory and autonomic neurons of vulva and vagina. And this, let us see how and where these are. We all know that estrogen receptors are abundant in upper vagina, and they decrease when we come down to the vulva portion. And both alpha and beta are there only are they present before menopause, but in post-menopause, only beta receptors are active. When we talk of androgen receptors, they are very high in the vulval regions. So that is where is the area which is responsible for the sexual orgasm. So vulval area androgens are very helpful. And when we talk of progesterone receptors, they are there in the vulva and whole vulvovaginal junction. So we have to understand when we go for the examination that these receptors play their role in different. This is a normal epithelium of vagina, which is a very, very thick with epithelium of 150 to 250 micromillimeters with a lamina propria, which is 350 to 550. And then there is a fibromuscular zone, which is again very, very well developed. You can see in this slide. Now, when we look in this slide, we can see that the menopausal area, all the layers shrink, and the basal cells and intermediate and superficial cells are there in the ratio of 0, 40, and about 60 to 80. So more of the basal superficial cells are there. And the superficial cells in vulvovaginal atrophy decrease to less than 50%, 5% in this atrophy. Again, there is a increase in vaginal pH because the vaginal microbiota act on glycogen-rich superficial cells, which are not there in the menopausal age group, and they produce lactic acid, which maintains the acidic pH from 3 to 5 to 4.5, which in postmenopausal women, because the superficial cells have gone to less than 5%, it goes to the acidic and not the alkaline side. So we can see that in GSM, the pH is decreasing, becoming from acidic is going to the alkaline side, and that makes the woman prone to UTIs and vulvovaginitis. Now, we all know that lamina propria contains elastin, and because of the decreased ergosity and stretchability, the decreased vascular supply, it becomes paler in color in the menopausal tissue, and there is a decrease in transient from the blood vessels. Further, there is the dryness of vagina because of the leading to dryness of vagina. The fibromuscular layer is also responsible for orgasm, which is because of the nerve sensation. So this is also decreased. There is decrease in libido, arousal, and orgasm. So the female is feeling less sexual and is not coming forward and telling us that she's got this problem, which we need to directly ask, help her, because that is, giving her a bad quality of life. She's not feeling good, and she's having problem with her husband. Then adventitia is also decreased because there is decrease in collagen and there is a prolapse also, and there is decrease, there is incontinence in the womb. The dryness is because of the decreased transient from blood vessels also. So when we look at the bladder, the effect on the bladder and urethra mucosa is again very bad. There is a decrease in sensory innervation, leading to urgency, frequency, dysuria, and urgent incontinence. Furthermore, loss of vascular supplies in the periurethral plexus leads to problem with the sphincter. Then there is loss of musculature in pelvic support, which is again leading to stress incontinence and UV prolapse. So when we talk of vulvovaginal atrophy or vulvovaginal problem, it occurs in 4 parts. First is the vulvovaginal area, which is responsible for dryness, and which is the most important part to start. It is about 93% and severe in 68%. Itching and irritation and burning is there in 63%. Discomfort and pain is there, and pain and pressure is with fissuring, and even cuts are there post-coital and discharge, followed by sexual, which is their problem is very high, up to 90%, with dyspareunia in 80%, decreased arousal in 34%, decreased libido in 24%, decreased orgasm in 19%, and clitoral bleeding is seen in 27%, and postcoital bleeding also. So urinary problems are there. It starts in the perimenopausal, increases as the age of the woman increases, with the dysuria, urgency, urge incontinence, frequency, nocturia. She's not able to complete her sleep, voiding difficulties, and repeated UTI, which is again a very, very big problem in the, recurrent UTI is a very, very serious problem in this woman. And then we talk of pelvic floor. We have urinary incontinence, pelvic incontinence, and fecal incontinence. And of course, pelvic pain because of the stretching and pulling. So it all affects the quality of life in the woman. There are different surveys, a Viva survey and Revive survey, which also tell us how big is the problem. There's a negative effect of life in 80% of women in Viva survey. Sexual intimacy is very bad, 75% of cases. Feeling less sexual is 68%. Feeling old, 36%. Marital relation, again bad, in 33%. Self-esteem is very bad, 20%. So the overall quality of life is very bad. And in the Revive survey also, we can see that loss of intimacy is there in 85%. Sexual enjoyment decreases by 59%. Marital relationship is bad by 47%. And there's a decrease in sleep in 25%, 9%. And there's the decrease of enjoyment of 6% in the life and other general lives. So when we talk of, GUS in this woman, we can see that in normal anatomy of vagina, the vaginal fornices are deep. It has got a lot of rugosity in the vagina. The arteries are well supplied. There is good rugosity. When we look at the left of the this slide, we can see that the anatomy of vagina is completely changed in the menopause. There is a loss of vaginal fornices. There is vaginal walls. There is loss of regal food. There's somebody unmuted. Can the admin mute everyone? Excuse me. Can the admin mute everyone? Thank you. So there is decrease in vaginal length also, and there is atrophy of labia minora as well as majora. So when we look at the vulva, these are the things we must consider. Thinning of vulva, the fat of mass is lost. There is a pale and thin vestibule. There are fissures. There is ecchymosis. There is clitoral regression. Phimosis of prepuce and clitoris, and there is hypo and hypersensitivity. There is urethral prolapse, urethral caruncles. I have seen cases coming to me with urethral caruncle in different stages. I'll show you those photographs in coming slides. You give them treatment, they just disappear. So we have to look for these things. Polyps, there is stenosis, there is intraorbital stenosis. I've seen the vulva and vagina completely joining together. There is, again, when we look at the vagina, it's completely dry. And it's pale and thin. It is erythematous. There is loss of rigor. There is loss of elasticity, stretchability, shortening of vagina. Cervix is flush with vagina. The pelvic floor is very weak. There can be a prolapse of organs. So when we look at a picture, you can see that it has already started. The thinning, there is, redness, the hair are less. Then you go to B slide, B picture, you can see it's grown further, it's become more paler. In the C slides, you can see the clitoris is very, very not seen at all. It is again very thin, pale. Any D, you cannot see the clitoris at all. So these are the different progression pictures. And this, you can see the fusion of whole of the vagina. You can't see urethra at all. And in this picture, you can see a urethral kind of vagina only. The whole vulva minora has completely joined together. This is a very, very common picture. Patient comes to you of telling us that patient has got vaginal urination, just like a child, just like a male. She's not having a female kind of urination. So these are the problems. And we can see that the vaginal wall is very, very fragile with the area of edema. There's a superficial bleeding and even deeper bleeding in some area. So this is very, very irritating, and these women are really suffering. There is small and very, very thin labia minora. And sometimes we can't see the labia minora in some of the women. And in these women, these are the women pictures of some of the women of earlier times where we could take pictures. The vagina is just not even one finger. The color is very pale. The vestibule is not there. The elasticity is completely gone. All these pictures of different times are showing us that the vagina has become less than a finger. So these women, when we examine, we have to keep this in mind, that we cannot examine with the bimanual with 2 fingers. We have to have different equipment in our menopausal clinic. We have to see them with well-lubricated single finger examination and a very, very small kind of speculum, specially kept in our menopausal clinic in our tray, so that we can see these women completely with the help of those small, very, very nulliparous kind of speculums. And we have to do a differential diagnosis in these patients from bacterial vaginosis, or these patients very commonly come with bacterial candidal trichomonas infection. Even bacterial vaginosis is very, very common in this. They can have dermatological lesions because of some kind of allergics, irritants and eczemias. There can be lichen sclerosis, which we cannot differentiate with the menopausal changes. There could be erosive lichoplanus, again, very, very complicated problem. Then there could be desquamated inflammatory vaginitis. There can be simple vulvodynia or vestibulodynia, vaginismus in these patients. They can come to us with pre-malignant and malignant lesions. There can be vulval intraepithelial neoplastic carcinomas, which we have to see. And there could be diabetes, lupus, or other psychological issues in this. There could be some kind of anticholinergics, which can lead to dryness of vagina. Antihistaminics are again responsible. There can be tricyclic antidepressants. They can be tricyclic antidepressants. That can also cause to vaginal, dryness, douches, detergents, perfumes used locally, synthetic clothing, sanitary products for, for nulliparity and abstinence. So you can see these few pictures of lichen sclerosis, which is very common to the women who come to us in menopausal age. We have to keep this in our mind, that they can be presenting to us with other problems also before examining all these women. A woman came to me with a laceration at 6 o'clock position, and which was very, very highlighted when I painted with iodine. So first and most important, when a woman comes to us, we have to take her history. What is most bothersome problem to her? Is it dryness? Is it dyspareunia? Is it irritation or soreness or postcoital bleeding? What is the duration? What is the severity of and degree of bother? Is it affecting her sexual life, and how far and how much? What is the quality of life? What drugs she's taking? Is she taking any other drugs which are important for her, any other problem she's there? Then is she taking any hormonal dependent, drugs which could be there, Then there is a pre-designed questionnaire which will come in the coming slides. It's a DIVA, vulvovaginal symptom questionnaire, that is very, very helpful, which takes us to detailed examination. Normally, we don't require any investigations like, vaginal pH or vaginal maturation index or VHI or all those things. But we may require to do a PAP or a colposcopy, sometimes a biopsy may be required. And in some cases, when they come to us with post-menopausal bleeding, we may require hysteroscopy or an ultrasound or cystoscopy if she comes with a urinary problem. So these are the investigations which we can decide once we find out what the problem is. We must keep all this in our mind. So visual inspection, I have already gone in detail earlier. In this picture, you can see there's scant pubic hair, shortened and narrowed vaginal canal, loss of labial fats, thinning or absorption of labia minora, narrowing of introitus, reduced vaginal canal, smooth, shiny, pale mucosa, and with loss of growth. In pelvic examination, as I said, thin, one finger, thin nulliparous kind of speculum, palpation of rectovaginal surface is very important. Then the contraction and relaxation capabilities have to be checked. Assessment of tenderness and palpation of levator muscles and bladder and urethra, because these women suffer from lot of stress incontinence and other problems. The evaluation of vaginal depth. In biomanual, we have to palpate the uterus and additive. A rectal examination and rectal reflex is very important in the patients who are coming to us with the overactive bladder or their stress incontinence. Then we inspect the vulva area completely, look for the vaginal thinning with the speculum, mucosa, porta, vaginal vault, and visit estrogen. Patient could already come to us and then cultures if we suspect any kind of infection. A lot of patients come to us with a pap smear report having bacterial vaginosis. So bacterial vaginosis is very, very important disease which is missed by all of us, because normally we don't look for clue cells in this woman. They come to us in pap smear reports. So we have to keep that in our mind. So this is a question, Diva questionnaire, in which we first, talk of during the past 4 weeks, what vaginal symptoms are there in her, scoring her vaginal dryness, soreness, irritation, and then make, and is anything which is making them comfortable, or has, what is it interfering with a daily quantity, daily life to life, and we, score it accordingly from 0 to 4. And then in second part, we, in the past 4 weeks, what symptoms have been there, which caused her, depression and embarrassment or frustration. So basically mental health in this part. How bad she felt about herself. I am having this problem. How can I avoid this problem? Her personal problem. Then followed by a question about impact on her, sexual part. So do you have any desire of having sex, and how frequently you have sexual intercourse and other types of sexual activity. In foreign, we are not having. They have these vibrators, I think. So there they use these vibrators if they are not having sex. And your ability to become aroused during activity and your ability to, have spontaneous withdrawal and all those things. Ability to spontaneous about sexual feeling, including self-esteem and masturbation, and amount of pleasure you express during sexual activity. So all these factors regarding sexual activity is covered in part C. In part D, we are talking about the ways the vaginal symptoms have influenced her quality of life, her body image. So do you feel like feeling old because of the vaginal symptom? Do you feel undesirable because of this symptom? Do you feel that your symptoms have something, very bad for you, and you may all these symptoms? So this is a very, very important score we can give to the patient till she is, waiting for some tests to be done. She can give us back to us, and maybe with the coming time we may be able to, make a coordination of symptoms, signs, and scores, and so on. So this is another symptoms score which is to be filled in by the clinician herself. Jyoti, how much time do I have? These are my last slides.
Ma'am, yes,
Yeah.
I would like you to sum up because
my next slide is summing up slide.
Thank you so much, ma'am.
So these are to be filled by us. I can share this, with you, all of you. And these are the same thing. And again, same thing about the sexual sex domain questionnaire, which is there, which we have to tell the patient to fill in. That will really help us. How severe is the sexual problem? Then there are some tests to be done, which I have already elaborated in my last few slides. And the other things I have already said. The laparoscopy may be, done. And these are the few pictures of the urethral caruncles. Urethral structure is another very big problem. For that, we may have to resort to the ultrasound for bladder volume and residual volume, and do a cystoscopy and calibrate the urethra. So treatment is not my part. So I'm not. There were 3 slides only, but I'm not covering. So to conclude, why the primary care physician to address the vaginal atrophy is very important part we must understand, because it can cause considerable issue in the postmenopausal treatment. And this problem is treatable, and it dramatically decreases the quality of life if we don't treat the patient. It does not resolve over spontaneously over the time, and it rather is progressive with the duration of menopause. The cause of vaginal atrophy, we must know that menopausal progression and level of estrogen is very, very important cause of the problem, and the level of estrogens, as they decrease, they are irresponsible. The possible symptoms we must have in mind, starting with dryness to insufficient moisture, dyspareunia, itching, burning, mucosal defects, petechiae, microfissulas, ulceration, inflammation, soreness, shortening, fibrosis, obliteration of vaginal canal and vault, and narrowing of vaginal entrance. Susceptibility of medical injuries have to be kept in mind, and adverse effect on healing of mechanical injuries is also be a very important problem, which we must keep in mind. And there are a number of treatments that are available with us, starting with lubricants, moisturizer, estrogens. Oral estrogen replacement therapies are required very, very infrequently, but in some cases, yes. Non-hormonal inserts are there available, and laser therapy is coming up in a big way. So all these things are in our hand, and we must offer them to our patients. They are all harmless and are very, very helpful. So our doctor's mission should not be to prevent it, but more importantly, it should be to improve the quality of life. That mission we should carry in our mind. And I always say that menopause is a fresh bloom in our life, where we are free from our worries of settling our family, our children, and everybody. And we must enjoy, restart, enjoy, and not suffer in silence. Thank you very much.
Thank you very much, ma'am. That was an excellent talk on the much less talked about topic of these genitourinary symptoms, and especially the sexual problems that menopausal women will suffer. And yes, we all, even as clinicians, we tend to shy away from discussing this topic, and having these kind of questionnaires and performers would definitely be so much more helpful to bring out the problem so that we can treat it appropriately. Thank you so much.
Moving on to our next session, we have a wonderful, wonderful panel discussion, and I'm sure 1 hour of a rigorous discussion will clear up many, will optimize our health in managing the medical challenges in 70+. For this, we have our moderator, Dr. Ragini Agrawal. We have this wonderful panel, Dr. Anuradha Khanna, Dr. Anita Shah, Dr. Jyoti Bhasker, Dr. Ujjwala Kedar. Over to Dr. Ragini, ma'am.
Okay, thank you, Jyoti. And very good morning to all of you again. And all the deliberation are really, really excellent. So welcome my all esteemed panelists. Professor Anuradha Khanna, she is a ex-HOD Banaras Hindu University, and she is an ex-president of Banaras OBGYN Society, and at present she is the president of the Varanasi Menopause Society. Not only this, she is the president-elect of UP COG also. So welcome, madam. Our second panelist is Dr. Anita Shah. I think she doesn't need any introduction. She was just immediate. She was a past Secretary General with Dr. Jignesh Shah. And we have worked a lot in the time of the COVID. Everybody knows the bubbly Anita. Next slide. We have with us Dr. Jyoti Bhasker. And when we talk about Jyoti Bhasker, the first thing come in my mind, the excellent deliberation of everything. And she's a secretary of the Delhi Menopause Society, a great academician, and her way of the presentation of all panels and the talks are really, really excellent. And at this time, she is working in the Cloud9 Purple. Welcome, Dr. Jyoti. My dear friend, Dr. Ujjwala, and nowadays she is famous as her mood court presentations in all conferences, which is really the need of the hour. And she's a great painter also. And she was an ex-president of Nagpur Menopause Society. Welcome, Ujjwala. Dr. Bipasa Sen, our incoming treasurer of the IMS from Kolkata. Recently, she has danced in AICOG, a wonderful dancer. I have never thought of. She looks so serious. Welcome, Dr. Bipasa. And my next panelist is none other than Professor Dr. Revati Janki Raman. She's from the Madurai Menopause Society, founder president. And she's also a great academician. She's a Lifetime Achievement Award from the IMA Madurai and Dr. Durusha Community Service Award from Foxy. Welcome, Dr. Revati. And one of four of us, Dr. Vanna. If I say I think all the dogs of the city, they all move behind Dr. Vanna. She has a big packet of the Parle-G in his daily, and she goes on the walk.
I feed pedigree, Ragini.
Okay, pedigree. Okay,
I get 20 kgs sacks and 6-7 per month.
So she has a great passion for pets, and we all know that she's a digital committee chairperson, past president of IMA Gurgaon, IMS Gurgaon, and Gurgaon OBGYN Society. Welcome, Vanna. Basically, one word was missing, that is the preventing management of the medical challenges. That is actually what I want to talk about, the prevention. We all can manage when the disease can happen, but we have to focus when we talk about the elderly females. We have to talk about the prevention before they really end up with the medical challenges. Why we are talking? Because globally percentage of the population over 65 is increasing, and as the healthcare system is not really prepared for them. And we always say that the frail people, they are contingently impaired, but I don't think so. We don't want to be. And some nations are aging even faster. Now is the time for public health community to plan for older aging wave, which is really going to come. And the aging process currently encompasses more than a generation and exceeds 3 decades. So when we talk about the definition by WHO, there's a young old. They are between 60 to 70, they're old between 70 to 80, and the old, they are 80 plus. When we talk about the old, then we can think of the sick, but 70, 80, then the chronic illness starts shaping, but we don't want to be ill, we still active. So this is the group which we are going to focus and going to plan something for them so they don't become a sick old. When caring for the older adults as a clinician or a caregiver predicting the future, what we have to see, the normal aging, common diseases, functional, cognitive, and psychiatric disorders, and really it needs a great social change when we talk about it. So getting ready for the decade of the healthy aging, that is 2021 to 2030, That is also one of the goals of the WHO. So what is healthy aging? Basically, live independently is number one and maintain the quality of life. It is the process of developing and maintaining the functional ability that enables well-being in the older age group. So ability to meet one's basic need, ability to learn, grow, and make decisions, mobility, ability to build, maintain relationships, ability to contribute, and functional ability combines the intrinsic capacity of the individual and how people interact with their environment. So adding more years to life can be a mixed blessing if it is accompanied by the adding more life to the age. That is important. What we want is a good life, not the longevity only. With birth rates dropping and the people living longer, leading to innovation are needed at all levels. We all know most of us, the children are going to abroad, we are living alone. We need a care and we want a good life in our late ages also. So what is the global status? 14% of the older people in the analysis were shown to be unable to meet their basic need. And every age, there's a lot of diversity in the older people's intrinsic capacity. So my first question to go to Dr. Ujjwala, as 80% of the adults 65 and the older have at least one chronic condition. So what are the main health issues in the women 70 plus?
Thank you, Dr. Ragini. You are talking about healthy aging, but we see that as women age, many chronic health conditions they keep in. And as you said, yes, one or more chronic diseases or conditions are prevalent in at least 68 to 80% of the women. There is a long list of the conditions which women suffer. But on the top of that is a hypertension. Beside this, high cholesterol, arthritis, coronary heart disease, and diabetes, which can be seen in 1 in 9 women, coronary artery diseases. Most of the women of this elderly age group, they die of this heart disease. Beside this, we can see depression, Alzheimer's disease, chronic pulmonary diseases, chronic kidney diseases, and we should not forget E3O, that is osteoporosis, obesity, and cancer and oral health. Obesity, as you say, see that it is a very high risk factor for the heart disease, even for the diabetes and cancer. Cancer can be seen in 1 in 5 women at this age group, and newly diagnosed breast cancers. And we all know that 70 plus women, the ovarian cancer peaks in this age. So we have to be very careful regarding physical as well as psychological conditions of the elderly people.
Thank you, Dr. Ujjwala. What are the main key points to remain healthy in the senior woman? When we talk about the prevention, we have to maintain those key points.
First of all, Ragini, coming to your first question, like we said, all these problems start in 65 plus. Basically, the origin is earlier. We have so many young people in their 40s, 50s having, even the women having so many problems. So all of them need that counseling from a very young age, not the 60 plus. We have to target from a younger population. And it is not a single factor. It's a combination of all factors. Like Ambuja ma'am said, exercise is very important. 150 minutes of exercise. Exercise would become a yoga, weight training, and basically they have to keep moving. That is very important. Even walking is good enough. Then we all know eating and having good choices for eating, having more proteins in their diet if the kidney function tests allow it. And the most important, I think, would be a managed stress and depression at this age, because people become stressful, they become isolated, they become lonely, and the depression starts coming in. So they have to keep moving with their peer group, maintain a good society relations with everybody, and also avoid all this alcohol, smoking. And the foremost is they don't go to the doctors regularly for their checkups. So they have to visit a doctor at least 6 monthly to annually for their normal blood tests, and women for their PAPs and whatever breast examination, what is. And also they have to remain healthy mentally. That is very, very important, so that they carry on their normal duties regularly, at least.
So thank you, Bandna. So now we are going to take each points in detail. I totally agree that we need that prevention from the early age, but I have seen when you talk about the menopause to 35 to 40, they really take our seat aback. What nonsense we are talking, because most of them getting married and they are having a child. So, yes, we have to initiate this process from the adolescent age group only, because we all know that bones are going to be healthy in the late adolescent and up to maximum 25. Then they are going to only decrease that. But this is the group when they are really concerned, the 60 plus, they are really concerned for their old age. And at that time, they don't know what to do, because suddenly every year the body is changing. So we have to focus on them because they are receptive. And if they are receptive and they are going to take care of their health, they will percolate to the youngers. Look, so this is a transitional society. When we are started talking about the menopause, we have come out of the closet. Even as a doctors, last few years back, people are not very serious about the menopause. When we are postgraduate student, there are 4 pages for the menopause only. So now we'll discuss in detail each and every point with Dr. Anita. The first line is get moving, exercise and physical activity, how it benefits aging women, and what are the factors which affect musculoskeletal health of aging women.
Thank you very much, Ragini, for an excellent this conference webinar. You have rightly said that as we know that not only menopause, but aging also affects the activity of a women at this age. And someone has rightly said, those who are lazy, those who don't have time for exercise, they have very much time to consult a doctor, and they have very much time to have medicines a lot and lot. So exercise definitely helps in any form, walking, jogging, cycling, dancing, anything. They will definitely help for maintaining the body build and maintaining the muscle power. So usually we encourage all these aging women to have something and something in the form of exercise. We all know that under the banner of Indian Menopause Society, we are running Club 35 Plus, and we are encouraging women. We are giving platform to the Club 35 Plus women to just making some dance. They can just create, they can just rejuvenate their hobbies, and they can help themselves for maintaining their weight. As well as we all know very well that along with exercise, there will be, if simple walking in the morning, they will just give the secretion of endorphins that will keep a woman very, very happy. So they will be devoid of their depression or stress also. And as we know that exercise will maintain their weight, so that obesity will not occur, and the risk associated with obesity like hypertension, diabetes, or heart problems, they will have benefit for getting rid of all those things. So in short, exercise will definitely improve their muscle mass also, they improve their bone health also. So in one or other way, we have to encourage each and every woman to do something and something as a routine in the form of exercise.
So thank you, Anita. So basically, when we talk about an elderly woman, there are only 3 things which is really going to bother them. One is obesity. We all know with the middle age, there's an increase in the visceral fat. And with the Ambuja madam talk, it is very clear that when the visceral fat increase, it causes lots of problems. All the metabolic syndrome come in and leading to all the sequelae of the diseases. And second thing is a newer word which was coined for the older woman. That is the osteosarcopenia. That osteosarcopenia is osteoporosis along with the decreased muscle mass. And the answer is only and only the exercise, resistance training, because we all know if the bone strength is not there with the aging, there's an inherent Deficiency of the enzymes which maintain the integrity of the muscles, that also decrease. So the exercise is the most important thing to maintain your all three factors. That is the decrease in the visceral fat and increase in the bone strength and increase in the muscle mass. So Professor Khanna, the next question is to you. The healthy eating, make smart food choices.
Thank you so much
to the health
Dr.
senior women.
Yeah, thank you so much. And it's really, first of all, a very happy Makar Sankranti to all of you. And now, regarding adding the sarcopenia, I will have a words to say that there are satellite cells in the muscle. There are satellite cells in the muscle, and if we regenerate them, massage them, give nourishment them, and give the exercise, they are going to rebuild the sarcopenic muscles, not to become weak. So this is very important. And to add on with this question, the diet, because this diet is very important from the childhood, as already been mentioned in previous lectures and discussions, that these diets should be not only for the aging, but it should start from the very early adolescent age group, childhood age group, and especially taking a lot of plenty waters. What I teach all the patients of all the groups even, that keep 4 bottles of fluids, waters in front of you, so that you will finish it from morning to evening. And along with, add the collagen fibers, like we are having a lot of chukandar, lycopene and many more things, gajar and everything. Just mash it and take it. That is a very important, not only micronutrients, not only vitamins, but also collagen in it. And also we are having those who can take eggs, they can take eggs. So a balanced protein, or this chena and cheese, which we can add, and a calcium supplementation is also very, very important. And fruits I prefer than fruit juices, because the pulp of fruit is having also lot of things which helps in endothelial dysfunction. With the aging, there is a lot of endothelial dysfunction, and the fruit and their pulp, even their peels, they improve, especially of oranges. They improve the endothelial dysfunction, because with aging, there is thickening of the vessel wall, and then the end arteries become less, and we will develop the sign of aging starting from up head to the tails, and especially the skin. They start sagging, the color is changing, the nail bed is changing. So all these whole fruits, grains, sprouts, they help a lot, along with the exercise. And we have to have low salt diet. The salt the taste buds are there. More we'll take salt, more we will start taking spinach and this and that. So we should learn how to decrease the salt in our diet without adding sardine salads and other things. And the mind is the most important thing. If you set your mind, and that we have to learn, because once we are aging, we have got lot of suppression, depression from outside, from my own families, from the surrounding. And as you said, exercise, they all things, they release endorphins, and we become positive and become out of depression. And we should love, first of all, us. Start loving us, the own. Then you can have a better things to understand and go further ahead. So I think we all know it very well. Thanks a lot. And I hope I justified your answer. Is it?
So thank you, Madam Khanna. So a nutshell, if you say that when you age, you think of your diet, please stop taking the junk food.
Yes.
And as far as the salt is concerned, I didn't take a single grain of the salt for a year. I can only tell you that's the best year of my whole 61 year of the life.
Yes.
I felt so energetic, and I lost weight like this in that year.
Yeah.
But the thing is that when you are eating the salt, it will give you a craving, and you eat more and more and more, and lots of the wrong kind of thing. When you're not eating salt, you are always eat the right kind of thing. That is also a very important message when we talk about the food in the elderly population. And if you see, now even the kids in the young child, the Pediatric Association has come up with this guideline, don't give the salt to the youngster till 1 year. So I think we have to think somewhere that salt is as bad as when we talk about the sugar.
But Ragini, it is not always easy. Once you left salt, I tried to do the same, but it is impossible for me. After 1 week, we had to start salt. I could not have anything which was saltless. Easier said than done.
Same with sugar also, no?
Yes. No, it's okay. But what I am saying, don't leave it, but you can decrease it. Don't put salt in each and everything. It's really tasty.
Like salad,
I will not eat one dish more than one dish of salt. And also how we have changed from the high calorie diets to the nutrient dense and low calorie diets. That is also very, very important to add in our practice. So
we can have other forms of salt. The rock salt and all are a little better than the normal.
They are all salt.
Like
all sugar, whether you take khand, bura, gur, they are all are sweet. The all salts are all salt. But if you really want to take salt, I will say if you are taking a less quantity of salt, please take those fortified salt only. Don't go to the Himalayan salt and rock salt because you will lose your iodine and it will cause another problem. So if you are doing some fancy thing, it's okay. But in the routine, the fortified iodine salt is much better when you are on a low salt diet.
Dr. Ragini, I would like to tell you, this fortified Tata iodine salt, the moment you expose it, it is whole iodine is gone. So I think rock salt is better.
Rock salt is better.
Iodine, yes. Rock salt is definitely better. Just add a small amount and don't allow it in salads and curd. Just in dal chawal, what you are preparing for summer, only in that. No, it's not in the curd and also not in the salad. That will save. Don't take at this age. We should
table salt.
Spices.
No
yes,
table
that
salt.
is true.
No table salt, as we have do in our PIH patient. We always say take the salt, but no table salt. Restrict.
Similar way, restricted.
So coming to Dr. Bipasa, as Madam Khanna has just said, we have to see about the calcium. So we always talk about the increase in regular calcium intake is synonym to the old age. First thing, take calcium with it. But why it is so important, or it is really important to take so much of the calcium? What should be the RDA for the older woman, and how we can achieve optimal intake in the older woman?
Thank you, Ragini, for first of all for involving me in this beautiful webinar. And before going to my answer, what you asked me, I would rather make a small comment on the past discussion on salt. What I prefer that at very old age, I mean 85 plus, we usually preferred allowing a little bit of salt to older women to prevent these things, the electoral imbalance and all. There are sometimes sodium deficiency and all these things. Salt restriction is more important in younger people than 85, 90-year-old people. I think so. And I have seen practically that in this group, 85 plus group, if there are started some incoherence and all these things, adding little bit of salt in food improves the scenario. Next, I am coming to this calcium. Calcium is always, we all know that calcium is important for our bone health, not only bone health, our neuromuscular health also. There is muscle contraction. Everything depends on calcium. So calcium is more important in adolescent age group, as you have already told, and we all know that bone building is over by the end of adolescence. So we should keep bone bank. We should improve our bone bank by adding calcium in our diet in adolescent period. That we should always keep in mind. And usually dietary allowance of calcium normally is 1200 milligram, 1300 milligram per day in adolescent age group up to 18 years. Thereafter, for males, it is 1000 milligram till 70 years. And for female, however, it is a bit more, 1200 milligram. And during pregnancy lactation, it is also 1200 milligram. And how we can take it if we think of diet, very simple, our Indian diet, like yogurt, curds, tofu, cheese, all these things, cottage cheese, and curd is a very common thing, and milk is there, milk, curd, these things. And apart from this, the vegetarian sources like broccoli and our sitafal atta, what we tell atta, these are very rich in calcium. And apart from this dietary source, if we talk of this calcium supplements, then there are so many varieties like calcium citrate, maleate, I prefer, but calcium carbonate is cheaper. And what, for all practical purpose, in middle age group, what I suggest, if she doesn't have any kidney problem or anything like that, I would rather say that you continue calcium. You apart from pregnancy lactation, then she has to take calcium in 1200 milligram per day dose daily. But usually in middle age group who doesn't have any apparent problems, I suggest them that take daily, but for 20 days per month. Then you can continue for 1 year, 5 years, like anything. And that helps, apart from without taking 30 days. Or some people take alternate days. That makes 15 days per month. This I have.
Thank you, Dr. Bipasa. So one thing, when I am making this presentation, what I have read, in the older population, we have to be little careful to give the oral calcium. Many time this oral calcium in a higher dose can cause a problem to them also, as Dr. Bipasa has also pointed out. And we should focus more on the diet. And calcium carbonate also in the older age group, we have to think, as she has said, it is better to give the calcium citrate maleate, because calcium carbonate, although it is cheaper, but it is more prone to develop the stones, and also it causes more of the gastric problem also. And in that way, calcium citrate maleate is much better than the calcium carbonate.
And
So
Ragini, it is very difficult convincing all these women to take calcium over the years. They would have it for 3 months once they have a problem and disappear altogether, and come 2 years later when they again have a problem.
No,
so they are not very consistent with their calcium.
I advise them to maintain on alternate days. Then they can continue on Monday, Wednesday, Friday, or Tuesday, Saturday, Sunday, Tuesday, Thursday, Saturday. In this way, they can continue.
This is a very good, I think it is a very, very good and practical point, because if they continue to eat continuously, it can cause problem. If you put on the alternate day, it will be the best solution, because they don't need to come to the doctor, and they don't want to come to the doctor and pay all the time.
And many a times they argue that they are taking sufficient dietary calcium, that is good enough, and they refuse to take the calcium also. So
Dr. Revati, same happened with my mom. Once I suggested her calcium, she would never take it. And once she had such a severe sciatica that she had to undergo a spine surgery, and then they told her bones are so bad. That is the time now she is taking calcium and would never forget one. So the one episode would lead to all these problems.
Exactly.
So Dr. Revati, next point we have talked about the sleep hygiene. So how it can help the healthy aging?
Definitely. Sleep is very, very important for healthy aging. And, even though we say that 68 hours sleep is very important, at the start of this webinar, we were discussing about this HPV, self-HPV testing for all gynecologists. And this very simple. Sleep hygiene is not followed up by many of the gynecologists. And if you take the entire medical fraternity, the least time spent for sleep is only physicians. And that is the problem. And poor sleep leads on to poor concentration, worsening of depression, and even dementia, and quick onset of Alzheimer's disease, and so many problems like that. And good sleep actually, on the contrary, gives a relief from various complications like decreasing the rate of insulin resistance, heart disease, obesity. And actually speaking, daytime sleep, if you sleep for a longer time, actually it may increase the weight. Whereas good night sleep will definitely control obesity. And obviously, when you sleep well at night, daytime activity and the quality of work in daytime will be very much good. And as such, it will improve the creativity, decision-making skills, and control of blood sugar. And so many good things will happen if you have a good sleep. And very important is when we are talking about all sorts of hygienes, menstrual hygiene, this, that, and all, we should follow the sleep hygiene. What is that? That is, we should have prioritization of sleep, and we have fixed time to sleep and get up, sleep positioning, pre-bedtime routine, and also pleasant behavior, bedroom environment. All these things we should follow it up. So good sleep is very, very important.
So many a time this sleeping disorders is also behind this, specifically in the elder women. If they are not able to sleep, it is better to go to a sleep medicine specialist. They are also available at least in the metro cities. And many a time when you go under the sleep study, they find some reasons for this sleep disorder also. And specifically the way the PCOD is increasing and metabolic syndrome in the elderly women, many a time they are reason for this disturbed sleep also. Nowadays, melatonin is prescribing by the doctors. Yeah. Even it is a OTC drug also for this good sleep in the night. And one can take it if it's really there's a disturbed sleep in the night, and it really helps them also.
Dr. Ragini, in elderly, they cannot straight away go for a sleeping pill or medicines like that.
It's not a sleeping pill. Yes, madam.
Changes, sir.
Dr. Ragini, I have seen in my practice only that once I walk for 20 minutes or half an hour before sleep, I have got such a beautiful undisturbed sleep, I can't imagine it. Just have a walk. It's our practical habit I have developed, that before going, after taking my food, then doing some work, before going to the bed, I just take 20 minutes to half an hour walk in my roof, and that makes me a wonderful sleep. So people, those who are having some problem, can try it. And I suggest to my patients also.
Yes, yes.
That is a
jump for any medicine first step. We have to go for
that is a bit, Anuradha, what told? Yeah. That is a little bit of exercise, which...
Whatever it is, in way, I don't know exactly.
Very little.
This is exercise on having the more endorphins. By walking in the evening, having some music around, that makes you wonderful. It's my experience.
So we are getting good tips. And I think it is going to help us also and our patient also. And these tips are very important because as such, we are not focusing on the menopause so much. I think we will compile all these things and come up with some guidelines in the IMS, how to maintain the 70+ women life in a good way.
Even doing meditation, going on bed, just relaxing yourself, focusing on your breath and doing meditation. It's not necessary to sit in yogasana position or padmasana and do the meditation. If you do meditation, which I do, will give you a better sleep.
That's mindfulness.
Yeah. And if you eat earlier at 8 o'clock and you go to bed at 10 o'clock, you will not get a gastric burn and definitely you will get a good sleep.
Dr. Ujjwala, then I was never able to make a presentation if I will do this.
Dinner and exercise stopped at least 2 hours before sleeping.
Yeah, one should do at least for 15-20 minutes of meditation will help.
Yeah.
And exercise in the evening also tires you off quite a bit and it helps you sleep also better. That's what I found out.
Coming to Dr. Jyoti Bhasker. Smoking, alcohol, use of these things really increasing in women also. Now I think more than 50% of the women is on alcohol. Even they are on the other substance uses also. So can you throw the light how it has more deleterious effect on the senior woman?
So thank you so much, Dr. Ragini, and I love the concept of this whole webinar talking about the 70+. So one thing I think it's very important for all of us to understand that the women over the age of 65, even in India, have taken over to smoking as well as to alcohol, and we should not push it under the carpet. We should accept it and give the advice accordingly. Now, second thing, we need to understand that women who tend to smoke have more adverse effects than the men have. So for women, it is extremely important that we tend to quit smoking. When we look at alcohol and smoking, they did a survey to find that why women over 65 tend to smoke or take on to alcohol much more. It was mainly found that it's because they want to relax, or it was mainly because of habit and to overcome their loneliness. As far as the effects smoking has, I think I don't need to elaborate the various effects that smoking has. We know it has got severe effect on the lung as far as the COPD is concerned, lung cancer is concerned, cardiovascular effects, the stroke. But one thing important is that smoking also increases the incidence of diabetes, and it makes it even more difficult to control the diabetes. Other effects smoking specifically is on the eye, the increased incidence of cataract as well as AMD, which is found to increase 3 to 4 times. Osteoporosis, we are anyway bothered in the postmenopausal, and if they smoke and they're drinking alcohol, then the risk of osteoporosis is much higher. Further, it's also associated with Alzheimer's. There's a study which says that smoking, the incidence of Alzheimer's, the cognitive falling down, that is also found to be much more. When we come to the alcohol, very interestingly, I read that how is it different alcohol in the adults that is above 65? Even if they take smaller amounts of alcohol, it has got a more deleterious effect as compared to when they were young. Second thing is that seniors above 65 tend to do a lot of binge drinking. It has been found that the binge drinking in them is much more than in the younger population. And alcohol has a major effect because when they tend to take alcohol and the effects are much more, the chances of falling, having fractures, everything tends to increase. Second thing, they get dehydrated very heavily, and that also further increases the chances of falling. It affects their medications, which they're already on. Alcohol has further effects upon these medications, and alcohol too increases osteoporosis, blood pressure, and everything. Interesting thing is that they found that when doctors or the medical profession talk to these adults about quitting alcohol and smoking, the chances of their quitting is much higher as compared to the younger ones. And when smoking is undergone or they tend to quit smoking, there's been a study by the American Lung Association. The effects are immediate. They found that within few weeks itself, they have found that the lung function tends to improve. The risk of cardiovascular disease, it tends to start coming down to as much as 1 week less in a couple of months. In 3 to 5 years, it barely becomes half, and about 15 years of stopping smoking. The risk is the same as that of a non-smoker. Similarly, for the cancers, which is the lung and the other cancers, also tends to reduce. So the importance lies on us, the medical practitioners, to correctly advise these particular people. They're very receptive. And if we tend to tell them the harmful effects of smoking and the benefits that it tends to do if you stop smoking, they found that the uptake of giving up smoking is much higher in these particular people.
Thank you, Dr. Jyoti. Here I want to add one more thing. Not only alcohol, not only smoking, the other things like pan parag and this gutka, rajnigandha, they are taken by the women in a very, very big. Well, they think it is not harmful, and they take the pan parag daily in an amount of even 30-40 gram. We all, when we were young, there was this thing, a long pouch, it's for you karke. So recently I have come across 3 women in my family only who are taking the gutka, and they developed in the later stage around 70-75 age group, they develop a gland here, and when it was found, it was they are having oral cancer, and it was all spread. And the only reason which we are able to find is this pan parag and rajnigandha, nothing else. So coming for the mental health. The mental health or mental wellness is essential to overall health and the quality of life. We all agree. It affects how we think, feel, act, make choices, and relate to others. Managing social isolation, loneliness, stress, depression, and mood through medical and self-care is key to the healthy aging. And I think in the COVID time, we all really experienced it. The only thing which maintains us sane is this webinar, talking to you all and talking to others also indirectly through these webinars. So as people age, changes such as hearing and the vision loss, memory loss, disability, trouble getting around, and the loss of family and friends can make it difficult to maintain social connection. This makes older adults more likely to be socially isolated or feel lonely. And it's a big, big problem. I think that's why Shobna said, don't do anything. Just visit those homes and sit with them, talk with them, and do nothing. It's a great boon for them. So, Dr. Ujjwala, again coming to you, how you define social isolation and the loneliness, and what is its impact on the older woman?
Yeah, even though these two things, social isolation and loneliness, they look that they are same, but they are actually different in the way that loneliness is a feeling when you are left alone, nobody is there to talk to you. Even at home also, our own family members, they don't want to talk to elderly people. This gives them more pain. They want to share, they want to talk. Even as you said, Dr. Ragini, the hearing loss is there, gait is not proper, they have sarcopenia, the memory loss is there, they can't go out, they can't make friends, they can't sit with the friends. So ultimately they are left with the social isolation. And as you all know that human is a social animal. If we don't talk, we don't do, it impacts very badly, physically and psychologically on health. As these people are seen who are lonely without social connections, they are seen more of suffering from heart disease, obesity, osteoporosis, even psychologically, they are mental decline, cognitive decline is seen more in them. Even the cancers are seen more in them, and Alzheimer's disease, even death and suicidal tendencies are seen. So if in abroad, there are the people, rented people, who they come, they take care of old elderly people, they talk, they just share your pain, your sorrow, and it is seen even by the studies when done on 2,000 people, when they are allowed to do, make new friends, new connections, then it was seen that they have improved physically as well as emotionally. My daughter always say, Mom, you are not going to get Alzheimer's disease because you doctors and we professional ladies always keep studying, keep writing, keep talking to our even patient's daughter, children's. And that is the reason that we are lively than, I think, housewives of that elderly housewives. Because ultimately what we want to share our pain, our pleasure, and our sorrow. But elderly women are left alone and they are cut off with their all social contacts. This is my saying. And we should even, for the elderly, we should focus on this point also, if we want them a healthy aging.
So basically, I think if you have heard the word of the satsang, I think this is the way of the older society to make the older people active. They have to attend that satsang after a certain age, so they can mingle socially, they can talk to the people who are their own age and maybe more active and not feel that social isolation and the loneliness.
But for that, Dr. Ragini, they have to have a good health. They should be able to walk, to go out. But that problem of elderly, as you said, that there is a memory loss, vision is not proper, gait is not proper, balance is not there because of lack of exercise. They are not able to even go out. And that is the reason in abroad they pay the money and they ask for unknown people to come and at least share something.
So I think we are here in the Indian Menopause Society to make it more popular in the age group of the 60-70. So even Anita, what was this thing? Our whole statement, fit at 50.
Fit at 40, fancy at 50, strong at 60, sexy at 70, independent at 80, naughty at 90, and healthy at 100.
So we are going to follow it.
Right.
So, and Dr. Ragini, one thing more. Today, my society is going to Apna Ghar to celebrate Makar Sankranti with the old woman and insane woman. So this
great,
is a
great.
motivation.
Yeah.
Great, madam.
Done
Very nice.
by Dr. Shobna. Yeah.
So taking
Just waiting
care of
for
the
them to
cognitive
come.
health
Yeah.
is the next thing. Cognition. What is cognition? That is the ability to clearly think, learn, and remember. Often changes with aging. Although some people develop Alzheimer or other type of dementia, many older adults experience more modest changes in memory and thinking. I think we all have this developing these things. Maybe the lack of the estrogen is considered one of the factor for this forgetfulness. And we talk about that 7 dwarfs of the menopause. It also one of the dwarf. So research shows that the healthy eating, staying active, learning new skills may help keep older adults cognitively healthy. So Dr. Bipasa, how different factors affect cognitive health and how cognitive training affects health outcomes?
Thank you, Ragini. You have just now mentioned in a nutshell the factors affecting cognitive health. I should enumerate these things that at least 150 minutes per week, that means 30 minutes, half an hour walk per day for 5 days a week. If she can afford, as Ujwala was telling that they don't have balance and all these things, if they can afford, that is best. Then apart from this, quit smoking and then lowering the dose of alcohol if she is in the habit of taking it. And then high quality Mediterranean style diet, that is very good. Actually, this Mediterranean diet, the name came from the people who in countries surrounding the Mediterranean Sea, France, Spain, Greece, Italy. The people living over there, they used to have traditional food, and that was mainly based on plant-based fruits, fresh fruits, vegetables, grains, seeds and legumes, nuts, all these things. And we have termed them Mediterranean diet, but these are very traditional food of people living in those countries, this surrounding Mediterranean Sea. And it has been found, it has been confirmed that these people are having healthy life. And they are not developing that chronic disease, many chronic diseases, even if they become old. So that's what the concept from that the concept of Mediterranean style diet has come. It is basically plant-based, fresh fruit, vegetables, nut, all these things. And engagement in mentally stimulating activities is very good. Like Ujjala was again saying that we people, we go on reading, writing, making presentation, but what I feel, we can percolate it to our relatives who are housewives. Like my mother, today is her 85th birthday. Today is her 85th birthday. So we have trained her how to use tab, how to use computer, and she is independent. We 3 sisters, she refuses to stay with either of us. She prefers staying alone with ayahs and all, but she uses computers, she uses tabs and connects with her grandchildren. 3 grandchildren, all are in US, UK, not in India. So she is doing on all these things. So being a housewife, being she was not tech savvy at all, but we have trained her and she could follow it, and she likes to be independent. So not only us working ladies, we can train our relatives who are basically housewife to engage in all these things. Apart from reading, writing, if they can connect, because now it is a technical time. So if they can use computer, they feel a bit happy. Then while using computer, they surf different channels and all, and connect independently. This independence, feeling of independence, all these things make them not, avoid Alzheimer in these ladies. So cognitive function is very, very important. A healthy lifestyle and engaging in these hobbies and all, I think this is very, very important, and we can percolate it to all ladies, whoever, even if she is illiterate, we can train her to use these things.
And I would suggest once we visit these old age homes, we have to tell these women how to maintain their cognitive health, because they are not doing it. Most of them have mental problems.
Yeah, two device. Vandana, we actually visit old age homes now. So in last old age home visit in December 2022, I came across two ladies who spontaneously started telling that we have big homes, 3-storied home. My two sons are there. Yes, they didn't ask me to come to the old age home. I like singing and all these things. But what I felt that they were lonely and their children, and they were expressing what they expected from their children. It is not true story that her two sons didn't allow her to come to the old age home. I think she wanted to become independent. That's why she came to old age home.
We just need to counsel them, because in the last visit, we had all these patients with mental problems, and one of them said that she had itching. And I said, okay, I'll do a video call with my daughter, who's a dermatologist, and we'll tell you how. And within moments, she itched the whole body and it started bleeding. And my daughter also said she has a psychological problem. She's just doing it to catch attention. She otherwise doesn't have any problem. So they would do all these things just to catch attention so that people can look after them. And many of them would say that हमारा तो बच्चों ने ditch कर दिया, मैम हम क्या करें? तो उनको cognitive functions develop करने के लिए कुछ skills सीखना पड़ेगा. Some instrument, something to even remember the mobiles would stimulate their mind. So if they don't have access to anything else, some mental these abilities have to be.
Nobody is ready to spend some time with them. That is the thing. Either through phone or sitting in front of them. Nobody is there to spare any time to share their talk, to listen to them. Then only this thing happens. Otherwise, if they have got some people whom they can share, whom they can talk with, then this thing doesn't.
It's actually very distressing to see these mental problems. The physical ones can be tackled with, but to deal with these mental problems, the cognitive function,
like Shabna told, you just go to
I
them.
think the most important thing, my take on it is that we human beings should start changing. We should not be dependent for anything, even for our health, on anyone. Why we want to chipko to our children? चिड़िया भी बच्चे को खिलाती पिलाती है, उड़ा देती है. So this thing we have to understand. And I think the community type of living for the older people which is coming, it is not bad. It is good. Expectation from the children is not good. Why they should spend the time with us? Yes. And only this factor, why not they are spending the time with us? This is start the whole process of the stress and everything, and those depression and loneliness.
Yes. If you're independent, changing Ragini right now, but the older age group people who have now aged, it is for them, it is very, very difficult to accept the fact that the children don't want to look after them.
Totally agree with you, Vanna.
Now what things
we are talking today is prevention of these. We people who are bothered about the menopause in Indian Menopause Society, we have to think to educate those 50, 55, 60-year women to think in this way that they have a good life, whatever they have, 70, 80, 90. You want to live for yourself. Yes, I totally agree with our Hindu traditions that at 50, you started the Vanprastha. And by 75, you go to the sannyas ashram. You remove all the moh maya. You are not related to anyone. You are only related to the supreme power and the God. So this is the way of the living. They said at the 50, you have completed your every responsibility. You start thinking for yourself. You start preparing yourself. And by 75, say everyone bye-bye and go for the next journey. So I think with this type of the, I can say, though, our Hindu traditions are very good, very good. And if you practice this thing, I'm sure you have all type of the happiness in your life.
But again, that is good. But on the other hand, like I told about my mother, she is very much family centered, but she wants to live independently, not with anyone.
I'm not saying leave them. Mentally, she is independent. What we want a mental independence.
She is associated with so many ladies organizations, and she cannot go all alone. So what she does, she connects with them through telephone and all, and give advice, and she writes for their magazine and all. These things is very
wonderful. Wonderful.
As and when for the privileged section of the society, it is the underprivileged we have to target who don't know how to go about these things.
Yes.
Here I want to say Dr. Pipasha ma'am has said very true. Nowadays I have seen older women watching YouTube. Even housewives are watching YouTubes and making dishes. So, and they take help even if their son and daughter don't have time. Then they catch the granddaughter, grandson. And even 5-6 year grandson have all the sons have all the knowledge of this mobile, and they usually teach. One of the Dr. Asha Bajaj is with us in NOGS, and I was talking to her, madam, आप Instagram देखिए, तो बोले मुझे नहीं आता, मैं अपनी नातू को पूछूंगी, he tells me everything. So your point was very true that they should at least learn mobile playing. They can mentally get distracted from loneliness. It's very
not necessarily gadgets, even if they don't know to use the gadgets in some other way, whatever way they know. Like some of my relatives, she is doing this, telling the stories to the kids or something like that. Whatever way they can engage themselves like that.
Yes. So although GSM is discussed in detail with Dr. Anju Soni in her talk, but I think this one chronic condition, which is a progressive disease, which is not going to go up with as you get old, like VSM. So, Dr. Anuradha, how you treat elderly 70+ women for this problem when they come in the older age group?
Yes, it's
and how much satisfied they are?
Yeah, it's a very important question and a very common problem also, because at the age of 60, 70 around, they definitely develop some problem. And Dr. Soni has also mentioned about how to examine. So examination and thinking and diet also, we have mentioned how to take anti-aging diet and the collagen component. But still at the age of 70, because of loss of androgen is also there now. And they develop all these symptoms. So they develop some cystocele, some rectocele, atrophic vagina, and gaping enteritis that makes it worse. And always feeling of vulvodynia type of symptoms, pelvic pain type of symptoms, recurrent UTIs are also there. So to prevent, beside those diet and exercise, Kegel's type of exercise, that we have to train all of them. Exercise is very, very important, along with nutrition, along with calcium, along with omega-3 supplementation, local application of estriol. I prefer estriol than estradiol because it is very weak estrogen and don't have any effect on uterus. So I ask them, whenever you are having such symptoms, beside exercise, nutrition, everything, you apply this estriol for at least 15-20 days in a month for subsequent 2-3 months. And then also after that, you can leave it and you can start reapplying it. So I found almost 90% of my patients are relieved, even in my this group of the family. I recommend all these things and I found it to be very, very useful. And I have given a talk in AICOG on recurrent UTI. And I found this has also got some genetic aspect. That is also there. But still our diet, our exercise and positive mind and exercise, they all are very helpful along with local application of estriol. I think everything has been discussed very nicely, so I'm not going to repeat it.
Thank you, madam. And we have to be very quick. The only 5 minutes are left. Yeah. Over to you, Vanna. How you treat these elderly women for the urinary incontinence, which is one of the major reasons for their social isolation?
Actually the treatment for the incontinence actually starts with counseling. So once a woman would come to you for all these problems, then you have to counsel them that you have to do the right amount, type of exercises, the pelvic floor exercises. You have to basically cut down on your weight. You have to avoid lifting heavy weights. Then you have to, the main problem is constipation. So more the woman strains, the more there is a dragging down sensation and cause problems. And they have to cut down on your alcohol, smoking, even caffeine would do all these. So these are the basic counselings. And if people can afford it and the tone is very low, all these exercising chairs like MCLA chairs, they work wonders. I had my best friend's mother-in-law who's 94 and having urinary incontinence, treat her by these MCLA chair sessions once a month, and she is quite relieved with all these pelvic floor exercises, which they can't do themselves. The second would be, if these don't work, we have drugs to work on these, the oxybutyrine, the tolterodine, the derifenicin, and now the latest, the miravigotin. All these do help women to have a lesser amount of symptoms. And also we sometimes need to put them on antidepressant medicines also. They also work out well in these women. And last of all, once they don't work, we had all these other devices like some prolapse. If there is then we could use a pessary. There was some Botox injections to be put in, but now last of all, the cosmetic gynae procedures. The radio frequency works wonders, the laser ones, in the mild urinary incontinence, the ones who would leak urine once they have to go to parties and not being able to wear good parties and to be using all these pads to prevent urinary leakages. The radio frequency works wonders. My own sister had relief in these symptoms. So all these, I'm rushing out because we don't have time. First of all, the prevention. Second would be the drugs. And the last but not the least, these procedures and the chairs which help you maintain this continence. And the latest would be a surgery, which we used to do earlier, but now we try and avoid it if we have these procedures to us.
Yeah, thank you, Vanna. Very precisely and crisply you have explained everything. Now coming to Dr. Jyoti for the depression, which is common in older adults, how you take out from the history their problem and how you approach to this problem.
So it is sometimes very difficult to be able to identify depression in the elderly people because the symptoms of the person who's taking care of that elderly or the person who's staying with the elderly, that is a family member, and ask them if there has been any change in the particular pattern. Like if the person was previously moving out for walks, have they stopped doing that? If they were going out getting dressed up, if anyone comes, they dress up and they come and sit outside. For the last few weeks, are they stopped doing it and keep saying, I don't want to change, I don't want to go down. Like with my father, who was there with me till the age of 85, he was there. He was very fond of going to the malls, going and seeing the movies. But over a period of time, I realized each time I would say, let's go for a movie or let's go out and do shopping. Especially on his birthday, he would love to buy a lot of clothes. He had started saying, no, I'm not interested. Why do I wish to wear it? I'm now old, I don't go out anywhere. So these sudden changes that we see subtly over a period of time.
Yes, we have to train the patients when they are coming with their daughters or daughter-in-law. We have to make them understand that for preventive health, they have to get themselves checked up and they should take care of themselves so that they may not have to need or may not have to depend in future on their children or anyone, because they want, then also they must be busy with their own life. And so basically every woman should remain fit at the age of even 80, 90, like that.
So use of
window of
opportunity. Next, Vanna, yes.
We should emotionally connect with them. this is what they are lacking. And once we connect with them emotionally, try and hear them out, they come out with their problems. Half of the time, they would not let you be aware of their problems. So just talk to them, listen to them, connect with them. And half of the time, listening to the problems can solve the problems for it. Rest of it, once we connect with them, we can counsel them well also. So that is very important for me.
So Shobna's vision is absolutely right. Dr. Anuradha.
Yes, my mother is 92 years old. So you can imagine. And she retired as a director of education. So I'm going all the things you are explaining. So I'm having all the things with me. I'm doing all those things and I'm following it very strictly. And I advise also my patients, and not only patients, their attendants, they are with them, and also to the society. Just people are calling me to come down because they are taking me away to Apnagar to do this celebration.
Okay.
So we all are so positive. I love you, Ragini, and all of you, that we, with the Menopause Society, we are doing great job and we will continue to do this great job. Thank you so much.
Dr. Ujjwala.
Okay, I personally don't believe in lifestyle modification. Because modification, you tell the patient at 40, 45 years of age, when already the endothelial damage has started, already the atherosclerotic patch has started forming. And if you really want to prevent all these changes and damages not to occur, then we need to catch them earlier in their adolescent age group. And if we teach and make them aware of all these chronic conditions, depression and all whatever we have discussed, then we will be able to see them as self-dependent, self-confident, self-reliant, and self-sufficient at their 70. This is my
Thank you. Thank you. Very nice. Very nice.
Compression of morbidity is our aim, for which we need to undertake the lifestyle modification. As Ujjwala rightly said, start it right from adolescence. Second thing is that not only gynecologists, even everyone at home should listen. That also we have to train them, educate them.
Dr. Vipasa?
Yes, spend some time with them and make them a bit tech savvy. And if any individual cannot spend every day with this, so make them connect with some other organizations like Ladies Club or something like that, so that non-relatives, they make friends with people who were unknown to them previously. So, or some literary group, anything of their interest, or some cooking group, or whatever be there, make them member of those group, make them a bit tech savvy, and you yourself try to spend a little bit of time with them, either physically or over phone every day. That is yourself. Try to spend a little bit of time with them, either physically or over phone every day. That is
Thank you. Last comment from Dr. Jyoti.
So I think everyone has covered everything, but only one comment I would like to say is that give them the security of economic independence. That is also extremely important for their mental health. So all the relatives, all the people taking care, ensure that they have money at their disposal to be able to spend how they wish to.
So economic independence. The overall thing is the economic independence. So beautiful words has come out at the end. I think the new key points are which we have discussed here. Thank you so much, the panelists, and thank you everyone who are listening it. Let's move forward.